I'm Donna Shalala. I'm pleased to be here with my colleagues to discuss an issue that's seasonally timely and perpetually important to the national biodefense. We're going to speak fluently, that's a pun, about our country's preparedness for pandemic influenza and the current threat that HPAI, highly pathogenic avian influenza, poses. Though flu may feel like more of a known quantity compared to emerging infectious diseases like COVID-19, we can't afford to let our guard down. Frankly, there's some question about we've ever had our guard up adequately to begin with. When we think of influenza, we most commonly think of a seasonal flu, which many may think is slightly worse than the common cold. But the historical record shows us that the variety and intensity of influenza viruses can be devastating. We need only to look at the 1918 Spanish flu, which took the lives of 500,000 Americans, many of them very young. The 2009 swine flu pandemic provided another opportunity to realize the importance of preparing for the future, potentially more deadly influenza strains. Our government has rightfully developed plans to address pandemic influenza, but plans are only pieces of paper unless we implement and adequately resource them. Avian influenza has been circulating through poultry farms across the United States for several years now, causing billions, if not trillions of dollars in economic damages to an industry we consider very vital to our economic and public health security. Yet until earlier this year, these outbreaks received little attention because they did not pose an immediate threat to our health, to human health, and because infectious diseases that threaten human health always get more public interest than those that affect animal health or plant health. But we must consider the indirect impacts of animal diseases. The revelation of bird flu outbreaks in dairy cows and finding more than a dozen human cases demonstrates the importance of investments in animal disease prevention before the diseases affecting them mutate and spread to other animals, including humans. With the increasing numbers of human cases and evidence that cases could be underreported, we hope that today's meeting serves to encourage many of our colleagues in Congress to hold hearings on this important matter. Although cases are currently subsiding for the moment, we have to anticipate another wave of infections during the fall migration season. Now is the best time for both the public and private sectors in the United States and throughout the world to get on with preparing for pandemic influenza. Hopefully, this meeting will help inform government activities in this space and provide an opportunity for stakeholders to provide their input in this matter. I'm looking forward to hearing from our colleagues from the federal government about the current response to the avian influenza outbreaks and what lessons they have learned so far, and whether their experiences with previous outbreaks have helped or hindered their work now. We will hear from some of the federal agencies most closely involved in influenza response activities. Eric Deeble, the Deputy Undersecretary of Agriculture for Marketing and Regulatory Programs, will provide the USDA perspective, including the important work of coordinating with our state, local, tribal, and territorial partners and the food and agricultural sector. Robert Johnson, the Director of Medical Countermeasure Programs at the Biomedical Advanced Research and Development Authority, will detail ongoing and future efforts by BARDA to develop and bring important medical countermeasures for addressing influenza to market. Vivian Duggan, Director of the Influenza Division at the CDC at the National Center for Immunization and Respiratory Diseases, will share the role her agency has in safeguarding the health of humans who come into contact with infected livestock, among other activities. This meeting will also have the benefit of an epidemiological perspective from Janet Hamilton, Executive Director of the Council of State and Local Epidemiologists, who will be able to speak to what she is hearing from her members on the ground about influenza threats. I'd also like to note that we are joined today by one of our own, Gary Parker, one of our ex officios, who will provide his perspective on the current crisis based on his extensive knowledge and background on these issues. We have a tremendous slate of speakers today, and I'm anxious to get into this discussion. Is Governor Ridge with us? Yes. Next, I'd like to ask the commission's co-chair, Governor Tom Ridge, if he'd like to make some remarks. Governor?
Well, thank you, Donna, and good morning, everyone. Excuse me. First, I'm very pleased to see and join my fellow commissioners assembled today to discuss pandemic influenza at what I would call a very opportune moment. At best, the recent outbreaks of bird flu in poultry and dairy herds can serve as a real-world exercise for national response, something that the administration and Congress can learn from, build upon, in the event of future influenza events. The states, localities, tribes, and territories remain the very first line of response in all of this, and the private sector plays an important role, particularly when it comes to food and agriculture. I am very encouraged to see representatives of those groups here today. We have assembled such an impressive group of participants. Thank you, Madam Chairman.
Thank you very much. Representative Upton.
Well, thank you, Dr. Shalala. Good morning, everybody. I'm happy to be here with all my fellow commissioners to talk about the National Pandemic Influenza Preparedness. This conversation is particularly important as it appears that Congress does continue to face many hurdles in passing a reauthorization of the Pandemic and All Hazards Preparedness Act nearly a year after the previous version expired. We hope that my former colleagues can break the logjam and pass this critical bill, which serves as a potent vehicle for addressing lessons learned from COVID-19 pandemic and the recent bird flu outbreaks. So when I was in Congress, my old stomping grounds, the House Energy and Commerce Committee, of which I chaired, held regular meetings and hearings to assess our preparedness for influenza, including seasonal influenza. The members of the committee understand the value of examining this issue regularly, given the potential for a strain of influenza to mutate and rapidly spread through humans. I hope that this meeting is going to inform my former committee's oversight in legislative efforts. I must admit that I'm troubled by the recent confirmed case of bird flu in a human who does not appear to have had any contact with infected poultry or dairy cows. Though federal officials continue to investigate, we cannot rule out the possibility of human-to-human transmission, and we must ensure the national response to current and future outbreaks of this flu strain take into account that very scenario. Our government developed a national strategy for pandemic influenza nearly 20 years ago in 2005. And it is more important than ever that the federal departments and agencies work with their state, local, tribal, territorial, and industry counterparts to implement that strategy and strengthen our resilience to a future influenza pandemic. We have a great collection of speakers from within and outside government to speak to our national influenza capabilities and needs. And today, I'm pleased to see some of my home state, Michigan, representation on our speaker list. The commission gives a very warm welcome to Dr. Nora Wineland, state veterinarian of Michigan, who has come here to discuss all the great ways that Michigan is leaning forward in responding to the biological threat. Also here again is Dr. Paul Friedrichs, the Deputy Assistant to the President and Director of the White House Office of Pandemic Preparedness and Response Policy. And from that perch, to follow Dr. Shalala with a pun, he does have a bird's eye view of the federal government's response to these bird flu outbreaks and can speak to ongoing federal coordination. For the ground level perspective, Mike McCloskey, founder and chairman of Fair Oaks Farms, is going to be here to discuss the needs of dairy farmers who are getting a crash course in protecting their livestock from avian influenza. Other speakers will touch on the biosurveillance and diagnostics required to help us understand the movement of avian influenza throughout the country. Dr. Christy Pabilonia, Executive Director for Clinical Diagnostics at the Colorado State Veterinarian Diagnostic Lab, can speak to state-level efforts to confirm bird flu infections with laboratory testing. And lastly, Dr. Yuri Fesko, Senior VP and Chief Medical Officer with Quest Diagnostics, is here to discuss the role that his company would play in ramping up diagnostic testing commercially in the event of widespread transmission of avian influenza in the human population as they did during the COVID-19 pandemic. So I look forward to engaging with our distinguished speakers and encourage a productive discussion with everybody. Thank you.
Thank you. Representative Green.
Just a brief observation. My hobby is photographing birds, and I do that all over the world. And last November and December, I spent a couple of weeks in Antarctica doing that, and I was really surprised and disheartened to see that the effect of avian flu there, of all places. We had to very carefully scrub our boots and disinfect our boots before going from the boat to land, and certainly when we came back again. And they were worried that they may have to stop visitation to some of those places for fear of the spreading of the flu. So its impact on the penguins and many other species is potentially very devastating. But it was just a shock to see, of all places in Antarctica, that it was so widespread.
Thank you. Senator Daschle.
Well, thank you, Donna. Each of our colleagues, especially you, have articulated our challenges very, very well and eloquently. I would just make 3 quick points. First of all, I think it's so critical, as Fred so aptly noted, how important it is that Congress finish the work on PAPA before the end of the year. That is our vehicle for addressing these many challenges. But we're not going to do it unless we better understand the implications of our failure to do so. And that, I hope, will be one of our goals today, is to better understand the complexities. I think it's fair to assert that every pandemic we've experienced, which, by the way, have killed more people than all wars put together, have started as an animal-borne issue. And I think we have to better understand and articulate that challenge as we look at our agenda today. Secondly, my concern is that in spite of all of that, I don't know that these issues even reach the top 10 right now as priorities are considered in our country. We've got to elevate this as a priority, and I hope that today's work and the extraordinary list of witnesses we have will allow us to do that. So I applaud Asha and the team for bringing together such a wise group of experts, and I look forward to the hearing today.
Thank you, Tom. Arnold, thank you.
Thank you very much, ma'am.
Dr. Friedrichs, of course, a retired Major General in the U.S. Air Force, and thank you for your service, is the Deputy Assistant to the President and Director of the White House Office of Pandemic Preparedness and Response Policy. Thank you for being here.
Thank you very much for the invitation to join you, and I apologize for having kept you waiting there. We were just wrapping up an interagency call on this topic, as a matter of fact. So thanks to the Commission for all the work that you have done, and also for the opportunity again to be here this morning. I'll start off with some framing comments and then lay out a few observations about this specific outbreak. So from a framing standpoint, as I was asked to take this job with the Office of Pandemic Preparedness and Response, one of the concerns that I brought to this from my time in the military and on the National Security Council was the need for interagency collaboration. And as many of you know, this office was explicitly created with bipartisan support to do exactly that. I'm very pleased to share with you that we've had, I believe, strong support and collaboration from our interagency colleagues. When we learned of this outbreak on March 24th, it was a Sunday afternoon, as I recall, we literally scheduled the first interagency discussion that Monday, so within 24 hours. That's very different than my personal experience with previous outbreaks, where it sometimes took weeks to get to the point that there was a clear understanding of who was going to meet, who was going to run the meetings, and how they were going to happen. I will in no way seek to assert that we've done everything perfectly. I think there's always learning opportunities and opportunities for improvement, but I do think that this is an indication that we have learned from previous outbreaks, and that the desire to create an office to do this sort of integration is having at least that desired impact as we go forward. Second observation that I would make specific to this outbreak and then more broadly to others is that trust remains a tremendously important attribute of any outbreak response. And as we've stepped through this, there have often been assertions or questions or comments made about why haven't we found this yet? Why aren't we doing that yet? Why can't we answer this question yet? I am very pleased to share with the Commission, and I hope that you've seen it. It's posted on both the Department of Health and Human Services website and on the Department of Agriculture's website, that we have now a consolidated research portfolio that we've put together. And that was a very deliberate effort to highlight the priorities of research and the breadth of research that's being undertaken as a result of this. This is in part things that we were already doing because we've worried about pandemic influenza for decades now, but most of it is specific to this outbreak. And I think it is a real credit to the people who are involved in this response that we've been able to find the funding and to leverage the existing programs, whether it's through NIAID or USDA, FSIS, and all the other myriad of acronyms of the different departments and agencies and components involved in this, to put together a very robust research portfolio to better understand this outbreak. And I go to that point next because the question that often comes up is, well, how can we possibly not know all the answers about this outbreak now that we're 6 months into it? And my first response to that is biology continues to be remarkably more successful at confounding than at clarifying many of these outbreaks. And we are, I think we know a great deal more today than we did in March, and there is still going to be a great deal to learn. We have talked about pandemic influenza, as I mentioned before, for decades, and we have asserted that this would be the cause of the next pandemic. Fortunately, we're not seeing that in humans at this point. I think in part because of some of the measures that have been put in place, but we need to continue to invest both in the foundational research that are done by departments and agents. Clearly can learn as much as possible from this outbreak as we go forward. I want to particularly give a shout out to our colleagues in NIAID. They have a number of programs that have done really important foundational research to better understand the influenza virus and to better understand what might be effective mitigation measures going forward. Similarly, on the USDA side, there's continuing work being done to look at mitigation measures as they learn more about how this is transmitted within cattle and among other species. But we are a long way from being able to say that we can describe with certainty what is happening with this virus. And I'll then go to my next point. As we look at this outbreak, it's actually useful to pull back a little bit and look at what's happened since 1996. So as many of you are tracking, this was primarily a migratory bird outbreak. And then in the last really 3 or 4 years, we've seen a change in the number of species infected by this virus, and also the fact that more and more mammalian species are affected by this virus. Now, I want to be very clear. I am in no way ringing an alarm bell. I'm not saying that the end days are near or anything apocryphal like that. But it is going to be incredibly valuable and important for us to understand as this virus continues to change and affect more species, why that is happening and what implications that has not only for this outbreak in dairy cattle, but also what implications that has 3 years from now, 5 years from now, and 10 years from now. This is one of those areas in which monitoring is important and having surveillance tools is important. I'll come back to that in a moment. But it is equally important that we acknowledge that there are some foundational research questions that we have to answer to understand why this virus is behaving differently in 2024 than it did in 2020 or in 2010. So that research point is incredibly important. And again, I want to say publicly my thanks to our colleagues across not only the federal government, but at the state and academic institutions that are doing a plethora of research programs to try and better understand this. The next point that I'll make is we have an opportunity to acknowledge the need for a shared vocabulary when we talk about One Health responses. I am very grateful for some incredibly well-trained human public health experts who have been part of this response and animal public health experts who have been part of this response. All of them speak English very well. They all write very well. They use often the same words and at times can be incredibly successful at confusing each other or talking right past each other, not with any malintent, not with any desire to confuse. But as a surgeon who is neither a human nor an animal expert in anything other than a very broad sense, it is impressive how differently two very well-trained experts, one an expert on animal health and one an expert on human health, can approach a very similar problem, can use similar terminology, and can mean completely different things. We've talked a good game about One Health. We've acknowledged the importance of it. We have built it as a line item in many of our plans. But the next takeaway that I would offer to the commission is that there's an opportunity for more work in this area. And I think this gets to things like exercises. This gets to things like looking at our plans and really breaking them down with everyone at the table, understanding in the animal health world and in the human health world what some of these terms mean and how they're being applied. That is not criticism that one side is right and the other side is wrong. It's an acknowledgement that those two communities have different approaches to similar problems. And that's work that I think we still need to do. And that's another lesson learned coming out of the past 6 months, is that we are going to have to continue to work on putting more meat on the One Health bones, if you'll forgive a very poor analogy there, in order to make sure that as both this outbreak and future outbreaks unfold, that there's an easier understanding or a clearer understanding up front about how both communities approach this. What you haven't heard me talk about is the plant health community. And I suspect that if we had plant experts, they would yet again have a third set of terms and tools that they use, which will differ from what the animal and the human health folks are using. So I would offer that as another observation. And I've often been asked, well, is it true that X is not working well with Y, or that there's a disagreement between A and B on this? And my answer frequently is, I've spent my life in the military brokering disagreements between the Army, Navy, and Air Force and Marines. That's a longstanding cultural, well-defined part of DoD life. What I've seen in this outbreak is actually something very different. It is not disagreements on science. It's not disagreements on the need for surveillance. It's not disagreements on whether we want to see cows dying or recovering. It's just a fundamentally different approach to how the communities address an outbreak and how we collaborate on a multi-species outbreak. And I hope that when people do write the history of this outbreak, that will be one of the things that's highlighted, that we really leveraged this outbreak to try and build a shared set of facts and a shared understanding of how we collaborate on these approaches. I'll give a shout out to the state of California as they're working through their outbreak right now. By all accounts, their public health human experts and their public health animal experts are working closely together. We saw a similar dynamic in Colorado. Those should be the exemplars that we aspire to and that I hope will be captured as one of the best practices from this outbreak. I then would transition to another observation from this. So we have talked for a long time about the importance of surveillance when we look at biopreparedness, biosecurity, biodefense. And I will continue to say that if you don't know where an outbreak is occurring, it actually is less relevant how many days it takes to develop a countermeasure if you don't know that you're responding to an outbreak. Those are not only complementary, they're integral attributes of a response. And part of what we've learned from this outbreak is that we need to continue to invest in our biosurveillance capabilities. There are variable capabilities across states, and because our system is structured the way that it has been now for 248 years, each state has taken its own approach with support from a myriad of federal agencies to develop their surveillance systems. As we now look at not only integrating multiple states' human surveillance data, but also multiple states' human and animal surveillance data, it's clear, at least to me, that there are opportunities to look more closely at what right looks like in the future and how we are able to do that on an ongoing basis, not just in response to an outbreak. There are a variety of data streams that exist today. Some we've developed as a result of this outbreak or have expanded as a result of this outbreak. But I think if we were to ask where to spend the next dollar to improve our biopreparedness and our biosecurity, certainly one of the areas would be in an integrated national surveillance capability that cuts across species, so that as we acknowledge the reality that the majority of human outbreaks actually are predated by an animal outbreak, we have greater visibility into what's happening. And again, I want to commend our USDA colleagues. We now get regular updates from the Wildlife Service. As many of you know, they do tremendous work on an ongoing basis, surveilling for avian influenza and other outbreaks, not only in birds, but in feral swine and in other species around the country. That data is now flowing in. Then we have the data streams that come from the food supply chain that tell us, is there anything getting into the food? Fortunately, that's worked very well, and our food supply has not been impacted by this outbreak. Then we have data coming in from emergency departments and from hospitals and from wastewater screening and other tools. But bringing all that together was a real labor of love for both CDC and for USDA. And I would not assert that we have completely and successfully integrated all of those data streams in a way that on a moment's notice, we can see everything every day, everywhere. There's still work to be done in that space. The next point that I'd make as we go forward with this is that as we look at a multi-species outbreak, there are different incentives or different tools that we will need to use in the future. And we're learning that very clearly in this outbreak to help us address concerns and to make it easier for people to understand the desired behavior that we're trying to get to. The Department of Agriculture, as you'll hear later today, has put together a number of programs that either expand existing programs or are specific to this outbreak. And on the human side, we have a number of programs that we offer. Vaccines for Children is a great example of a program in which we assure that all children who, for economic or other reasons, are unable to access vaccines otherwise would have access to those vaccines. It is also true that this country has adults in it. And I say that somewhat tongue-in-cheek, and there is no vaccine for adults program. That proposal has languished, unfortunately. And so it complicates our ability then to ensure that those adults who are exposed or at risk from an outbreak also have access to appropriate vaccines to protect them and to protect their families. And I think that's a real opportunity for us to tackle. You all are well aware that we talk about deliberate, accidental, and naturally occurring outbreaks. This is clearly a naturally occurring outbreak that's been unfolding for decades. And we are also at a point where access to vaccines, were they to be needed, is going to be predicated on funding and on the absence of a vaccine for adults program. And so I think that's an area, as you reflect on recommendations that you can make, that is worthy of continued consideration. How do we make it as easy as possible for people to access the tools that help them, especially if they are in rural areas or in areas in which, or in economic circumstances that make it difficult for them to access those sorts of medical countermeasures. A couple of other points to make before I wrap up here. We have gone back and looked at documents from the federal government and have found what we think is the earliest reflection on the need for a federal biosecurity, biopreparedness, biodefense strategy from 1996. And not surprisingly, in 1996, that document signed by President Clinton said, we need to have more investment in biosurveillance. We need to expedite our ability to develop medical countermeasures. We need a more robust R&D portfolio that cuts across species. We need better interaction with our industry partners, and we need better communication tools. If you wind the clock forward to 2022 and you look at the National Biodefense Strategy that the Biden-Harris administration signed out, and if you look at every document that every administration has signed out between 1996 and 2022, they pretty much all say the same thing. And I would ask the commission to consider how we can be so consistent in our recommendations and continue to confront the same challenges. I think you have a real opportunity as commissioners, not only to continue to describe the broad problems that are implicit in biopreparedness and biosecurity, but also to address the fact that we've been having this conversation for a long time now and have made really limited progress in some of these areas across multiple administrations. And I am not, I am very much living in a glass house, and I am not ever going to say that I'm throwing stones or criticizing anybody in this. I'm just acknowledging the complexity of this and the reality of the boom and bust cycle that's implicit in biopreparedness. We marshal great resources when an outbreak happens, whether it was 2006, 2014 Ebola, pick an outbreak along the way. And then we struggle to sustain that investment going forward to really get the substantive changes in place and sustained that need to be in place for us to truly be prepared. So I'll offer a couple of very specific points there, starting with biosurveillance. In 2024 and beyond, we should have integrated biosurveillance capabilities that pull together the state capabilities as well as data from electronic health records and the other sources of data that help us to understand when an outbreak is occurring and how widespread that is. What's impressive to me in this role and truly at times somewhat inspiring is to see the sheer quantity of data that exists in different streams and the opportunity to better integrate that data to build a layered picture. We should be able to look with a push of a button at wastewater screening data overlaid with the location of whatever species of farm or livestock facility is affected by an outbreak, along with emergency department data and vaccination data and all of the other data that exist in our system. And to the credit of CDC and USDA, they're moving in that direction, but we're not there yet. And that's a goal that we should I hope, agree on and very clearly articulate as a desired end state, that we need that sort of an integrated surveillance capability to be able to see ourselves, whether you're talking about rural Nebraska or New York City, and to be able to lay all of the data streams that exist across the federal government and with those states that are willing to share data with us. So in real time, we can appreciate when an outbreak is happening. A subset of that discussion is the tremendous work that's happening to collect genomic data and to be able to link that data to everything that we learn about an outbreak. And again, I think if you look at this outbreak, you'll see that we posted thousands of sequences on several platforms, and we continue to work on getting those posted as quickly and as comprehensively as possible. But automating processes in a way that that is possible today, and including as much data as possible because it's already aggregated and can be attached as metadata, is another, I think, lesson learned from this that makes it much easier for researchers to see as quickly as possible everything that we know about a particular outbreak. And I think we've made real progress in that area. But as you look at the opportunities to automate linking different data streams, we could actually do that even more efficiently and effectively than we are able to do today with some of our manual processes. Another best practice, and this is a shout out to our CDC colleagues, leveraging electronic health records for syndromic surveillance. In a case like this, or in an outbreak like this, where in the human side, the primary clinical measure is inflammation of the eye or conjunctivitis, that's not something that we previously looked for on a recurring basis. Conjunctivitis has not been a primary marker for smallpox. It's not been a primary marker for any of the other things that we routinely surveil for. And it brings up the opportunity to highlight that we should have an adaptable surveillance system working, especially with those healthcare systems that have electronic health records, in which we can quickly collaborate on looking for whatever the symptomatology is that's prevalent in an outbreak, and do that in a very collaborative and timely fashion. And again, I really want to commend our colleagues who are working on that on the human side, because there's great promise in being able to do that quickly and, more importantly, consistently across multiple platforms, so that as data is coming in, we understand that we're truly looking at apples to apples across the nation, and not an apple, an orange, and a truck tire, depending on which system you're looking at there. If we go from surveillance to medical countermeasures, the good news was we had invested in medical countermeasures for avian influenza, and our ASPR colleagues had maintained those investments through the Strategic National Stockpile. The better news is the testing that we've done to date indicates that those medical countermeasures are indeed, or should be effective at mitigating risk from this particular virus. But as this virus and others continue to mutate, we should double down on the 100-day challenge and on the other goals that are laid out, not only in our national biodefense strategy, but also in global documents committing to the ability to more quickly develop medical countermeasures when a new outbreak occurs. It is good that only 15 people have been infected with this or have documented infections of this, and they've all fully recovered. That is very good news. It is unlikely that that will be the outcome in every outbreak. And it would, I'm afraid, be easy for folks to draw the conclusion that, well, we're probably in a pretty good place. This is working out okay, so we don't need to invest more. If you look at the SNS and what's in there right now, there are clearly recommendations that have been brought forward by multiple administrations to make the SNS more robust, so that we are looking at how we can have pre-positioned tools, not only for the most common pathogens, but for other families that are less likely but more consequential were they to cause an outbreak. And this is an area where, not only in the medical countermeasure space, but in the R&D space, we have an opportunity to look at that portfolio and to really make sure that we are addressing the broad spectrum of threats as we go forward. Very grateful for the collaboration that we've had with departments and agencies on an initial look at the federal government portfolio on viral pathogens. And as we look across the government, tremendous investments being made. That sort of visibility in those investments then allows us to say, okay, it looks like maybe we have a little bit less investment than we'd like to have with this particular viral family. And perhaps we can not do 8 projects on the same thing across all the departments and agencies with a different viral family. But there's a real opportunity there to ensure that shared visibility of the investments that we're making, and then to understand how to rationalize those investments against risk being defined as the likelihood of something occurring and the consequence of it occurring. And we think that there's another opportunity with that as we go forward. There's great work being done, and this is not to take away from anybody's research, but to highlight that there's a real opportunity to look at that portfolio. And this outbreak is highlighting, look not only at the investments in the human research space, but also in the animal research space. And then we'll need to add in the plant research space. And I would say that, the extension of that is understanding how the rapid changes in biotechnology, in compute, and in AI will change our approach to these research projects. We now have the ability, strictly using computers, to do computational assessments of what's in the pharmacopoeia and whether there are promising potential candidates that could be used in a future outbreak, or vaccines that could be repurposed, or small molecules that could be designed as bespoke medical countermeasures for different pathogens as we go forward. That's incredibly exciting work. And it's all work that can be done on computers. You're not having to do as much wet work or lab-based work as we have historically had to do. It's plausible. It is absolutely plausible that in 5 years, the United States could lead the world in partnership with CEPI and other key nations investing in this space in having a portfolio of early medical countermeasures and diagnostics that we've developed across pathogen families so that we are prepared for whatever the next outbreak is, regardless of whether it's a commonly occurring or a rarely occurring pathogen. And that's an exciting vision that I hope you all will share and address in your reports as you go forward. I'm mindful of the time here, and there's a lot more that we could cover in this, but unfortunately, I'm going to have to head back across the street here in a few minutes. So I'll end with a couple of thoughts. We are seeing across the spectrum, not just with this outbreak, but in survey after survey, that we're at a point right now in which there's really fundamental questions about the advice that's being offered, whether it's for therapeutics or for vaccines, for non-pharmaceutical interventions. And as you all consider what recommendations you will make, I would recommend and ask that you explicitly address this issue, whether you call it communication or whether you call it trust. There's a number of terms that are being used for it. It's undeniable, and the survey data is very consistent now, that a large segment, not only here in the United States, but populations around the world, for a variety of reasons, now question the advice that's offered to them. And there's work that we must agree to do to understand the roots of those concerns and to be able to address those concerns more effectively as we go forward. I'll go back to COVID, in which we found that some of our most successful outreach efforts were not putting some person that looks like me in a white coat in front of a microphone talking about scientific terminology and mumbo jumbo. It was having community leaders, sports leaders, entertainment leaders, a whole variety of messengers sharing their personal understanding and their experience as an effective way of amplifying the medical message or the scientific message. There's much that we can learn from those experiences and how we more effectively inform the choices that individuals make, that parents make, that employers make. As my team and I have had the opportunity to meet with industry leaders around the country, they've highlighted this point also, that they're spokespersons within their organizations. How do they convey a message in a way that sounds trustworthy or trust engendering, and that is understandable to their workforce? School leaders have highlighted that. How do you talk to a kindergarten class? How do you talk to a high school class? What are the best practices? What are the lessons that we've learned over the course of many years of communicating on a myriad of topics, and in particular in the health space, so that we can inform the choices that people make? And I look forward to the recommendations and to the insights that I hope you all will include in your future publications. The next point is on the importance of bringing everyone to the table. There is no biopreparedness for this outbreak or any other without having all the stakeholders at the table. And those stakeholders include the obvious ones like the CDC or the USDA or other federal departments and agencies. And they include our state and local and regional partners. And they include the healthcare delivery experts on both the human and the animal side. But they also include industry. And we can't ignore the fact that there are no vaccines that the federal government by itself produces or that any state government produces. There are no medical countermeasures that are widely available and scalable that are only produced by the government. This is a collaboration, and we need to continue to work on building those connections across both the government and the non-government and the industry space so that we have those in place before an event and not have to build them during an event. I'm very grateful to the authors of the legislation that stood this office up and explicitly called that out. We have had, I think, we've derived great benefit from our discussions with our industry partners, as we have with our partners from rural health and from a myriad of other areas. But these connections, especially with industry before an event occurs, are crucial to our preparedness and our ability to adapt our response as we go forward. And I hope that you will bring your expertise across your myriad of backgrounds to bear on insights into how we can do that more effectively and more consistently going forward. This should not be an us versus them narrative with industry. It's got to be an us narrative as a nation, recognizing that any response depends on all the levers going forward. I'll end with a personal anecdote. I've spoken with you before, and I've mentioned him before. My father will be 98 in January. My mother's 88. My in-laws are in their 90s. They've seen a lot over the course of their lifetimes. And as we talk about this, what is encouraging to me is to hear them describe how far as a nation we have come, because they actually remember the days when children were dying, literally dying of polio across this country. They were dying of rubella, they were dying of measles, they were dying of a whole host of things that today we look at and we think, oh my gosh, there's a cluster of 14 cases of measles in Oregon. What are we going to do about that? We should not lose sight of the fact that as a nation, we chose to work together. We chose to invest in science. We chose to collaborate in finding cures, in finding preventive tools to protect our children, to protect our loved ones, and we succeeded. The health of America is a result of decades of work and decades of collaboration, decades of commitment to preventing the preventable, mitigating those things that can be mitigated, and trusting that at the end of the day, our shared interest was the priority at every level of our nation. As you craft your next report, I implore you, help us recall how far we've come in this discussion and how much is at risk if we forget that shared commitment that's captured on every single piece of currency since our nation was founded. E pluribus unum is not some abstract thought. It's good public health. It's good animal health. It's common sense and it's common decency. Help us bring the discussion back to what makes this country great, which is our shared commitment to each other. That's how we've been so successful in the past and how we will be even more successful in the future. I thank you for the work that you're doing. I apologize that I can't stay longer. I look forward.
Thank you, General. General, I have just one quick question, and that is, can we learn something, since you brought up the trust issue, can we learn something from the land grant institutions and the Department of Agriculture who have had agricultural extension agents over the decades that have built relationships with the farmers in this country, where they have trust as they're translating science to improve and really for the safety of the agricultural enterprise?
The short answer, absolutely. And the longer answer, I'll say, if you look at the outbreak of H5N1 in minks, one of the really important inflection points in that outbreak was when they brought in their veterinary schools to help with the outreach to the owners of the farms and those workers on those farms. Look, I'm a surgeon, and there's the stereotype of what a typical surgeon brings to the table, and there's a sense that we have a pretty good understanding of what needs to be done. What I'll share with you is we should have a great deal of humility in coming to the table right now when it comes to biological outbreaks. It's easy to throw stones and criticize because no outbreak to date has been perfect, because it's hard. Biology is incredibly hard, and it keeps changing. The rules keep changing, viruses keep mutating. We should bring a tremendous, profound sense of humility and respect for how complex these outbreaks are, and therefore commit to working together across all of the stakeholders who can help us with it. Again, thank you very much for all you're doing.
Thank you. My co-chair, Representative Upton, will introduce panel 3.
Well, thank you all for joining us. We are joined on this panel with Eric Deeble, DVM Deputy Undersecretary for Marketing and Regulatory Programs at the Department of Agriculture, Robert Johnson, PhD, Doctor, Medical Countermeasures Program, Biomedical Advanced Research and Development Authority, Administration for Strategic Preparedness and Response, Department of HHS, and Dr. Vivian Dugan, Director of the Influenza Division of the National Center for Immunization and Respiratory Diseases, Center for Disease Control and Prevention, Department of HHS as well. We will start with Dr. Deeble. Thank you.
Thank you, sir. Thank you. Good morning. I'm Dr. Eric Deeble, Deputy Undersecretary of
Could you
USDA's
just move
Marketing.
that mic just a little closer to you?
All right.
Thanks.
Always worried about blowing the volume on the guys on the side. Good morning, everyone. I'm Dr. Eric Deeble. I'm the Deputy Undersecretary for USDA's Marketing and Regulatory Programs. Look forward to speaking with you all about USDA's portion of the unified federal response to address the emergence of H5N1 in dairy cattle. Since March, H5N1 was first recognized in dairy cattle. USDA has been collaborating with the Office of the Pandemic Preparedness and Response, the Department of Health and Human Services, state departments of agriculture, industry associations, and of course, dairy farmers. Through this partnership, USDA has implemented strong measures to minimize the spread of H5N1 in dairy cattle, research into the etiology and epidemiology of the disease, biosecurity enhancements to protect herds, and outreach and financial assistance to states and dairy producers. Our collective efforts have allowed us to protect the health of farmers and farm workers, the health and welfare of their livestock, reaffirm the safety of our nation's food supply, and ensure the continued sustainable operation of our dairy sector. USDA has extensive experience in confronting highly pathogenic avian influenza, addressing the current outbreak in poultry for more than 3 years, and helping producers to protect their flocks for more than a century. While the emergence of H5N1 in dairy cattle was unexpected, it is a disease that USDA has studied, understands well, and is equipped and resourced to address. USDA's early work to address H5N1 was spread across several agencies, including the Animal Plant Health Inspection Agency, the Agricultural Research Service, the Food Safety Inspection Service, and the Office of Chief Economist, and focused principally on investigating the nature of the virus, conducting genomic evaluation of the virus, determining how best to ensure the safety of the milk supply, and examining the potential impacts on food prices, farm income, and the economy. As we learned about the disease, and that it was the result of a single spillover event from wild birds into cattle in the Texas Panhandle region sometime in the winter of 2023 and 2024, and that the disease had subsequently spread between herds in the region and then to other states through the routine shipment of cattle, it became obvious that it was necessary to limit the movements of potentially affected animals. On April 24th, USDA announced a federal order that mandates testing of all lactating dairy cattle prior to any interstate movement, mandatory reporting of positive influenza A tests results in livestock to the National Animal Health Laboratory Network, and confirmatory testing of any positive findings through the National Veterinary Services Laboratory. Under the federal order, producers continue pre-movement testing, and USDA has collected data from across the country, improving our understanding of the virus. The NALN and NVSL laboratories have conducted nearly 60,000 PCR tests since April 2024, representing millions of animals. USDA then expanded their work to provide producers with financial assistance to help them when challenged by H5N1 to pay for biosecurity plans, trainings and audits, testing associated with the disease and shipping, veterinary costs to treat animals that had become ill, personal protective equipment, and the safe disposal of milk from sick cows. USDA also established a voluntary H5N1 dairy herd status program to help producers test their herds via weekly bulk milk sample testing so that they can demonstrate the disease status of their herd, and if they are free, to be able to move and ship those cows without having to test individual lots. USDA then expanded the Emergency Livestock Assistance for Livestock, Honeybees, and Farm-Raised Fish Program, more commonly known as the ELAP program, to compensate eligible producers with positive herds who experience loss of milk production. While dairy cows that have been infected with H5N1 generally recover well, and there has been low rates of mortality associated with the disease, it does dramatically limit milk production, causing economic losses for producers. USDA can support producers with the ELAP program to offset some of these losses. And of course, by providing a financial incentive or support for the loss of milk production, USDA provides a strong incentive to producers to test their herds and a good safety net if they are found to be positive. In May, USDA announced the transfer of $824 million from the Commodity Credit Corporation to directly support these response efforts. Finally, USDA understands that farmers are busy, and so that we've been working very hard to make sure that they know about these programs so they can get whatever help they might need on their farms. We've been communicating through mailers, fact sheets, in-person presentations across the country, and participation in public forums such as this. The department and our agency partners will continue to communicate our best understanding of H5N1, the practices farmers can implement to protect themselves, their workers, and their herd, and which supports are available to them as we work together to develop a vaccine and implement enhanced biosecurity to protect us all. Thank you.
Thank you, Dr. Johnson.
Good morning. First, I'd like to thank the committee for this opportunity to be here with you today to discuss BARDA's role in the federal government's preparedness and response efforts against pandemic influenza, particularly as it relates to medical countermeasures or MCMs. The Center for Biomedical Advanced Research and Development Authority is located within the Administration for Strategic Preparedness and Response, or ASPR, within the Department of Health and Human Services. Our mission is to develop and make available medical countermeasures by forming unique public-private partnerships. Our mission space is broad, covering chemical, biological, radiological, and nuclear, or CBRN, and related threats, as well as pandemic influenza with our annual appropriations, and supporting emerging infectious diseases response with supplemental appropriations. Since its inception, BARDA has been responsible for the advanced research and development, manufacturing, and procurement to protect against and respond to pandemic influenza. During this time, it has responded to both H1N1 human pandemic, as well as increased levels of preparedness and response to H5 and H7 outbreaks or elevated levels of concern, due in part to increased circulation of the disease and the virus, very similar to what we are seeing in the current situation. Because influenza strains of pandemic potential are constantly circulating and evolving, a simple approach for developing, licensing, and stockpiling vaccines is not a feasible option given budget and time constraints. Rather, much like the model seen with seasonal influenza vaccine ecosystem, BARDA maintains an evergreen approach to pandemic influenza preparedness, particularly for vaccines. Working very closely with agencies within Health and Human Services, as well as across other government departments, as well as our external influenza researchers and other experts in MCM development, BARDA continually monitors circulating influenza viruses of pandemic potential to understand their susceptibility to currently available medical countermeasures, including antivirals, as well as cross-reactivity to existing vaccines. As such, our efforts regarding the current H5 outbreak have taken place in the context of this existing infrastructure. A key component of BARDA's Influenza and Emerging Infectious Diseases Division is the National Pre-Pandemic Influenza Vaccine Stockpile, or NPIVS. Created in 2005, the NPIVS coordinates these activities for BARDA, as well as maintains and manages contracts to support large-scale commercial vaccine manufacturing should it be needed. The value of this effort is exemplified by the fact that vaccines from seeds that are a good antigenic match to the currently circulating strain were previously identified, had been manufactured, and were in clinical trials prior to the current outbreak in dairy cattle. Further, our colleagues at CDC and NIH were able to use existing infrastructure to rapidly determine that by sequence, the virus was susceptible to currently available antivirals. Currently, strategically, this continual tracking of circulating viruses and updating and testing of vaccine candidates forms one part of BARDA's overall strategic plan, with the other two components being development and regulatory approval of new vaccines, therapeutics, and diagnostics, and third being maintaining antigen and adjuvant manufacturing capability to produce vaccines in the event of a pandemic. Fundamentally, the biggest challenge in this environment is not what needs to be done, but rather, with available funding, what do we prioritize? These priorities evolve over time, so it's never a static situation, rather one that requires constant reassessing. For example, lessons learned in development of new technologies that can improve pandemic influenza response capabilities often drive changes in MCM development, prioritization, and strategy. In short, the existing framework and strategic plans that have enabled BARDA to support the current dairy cattle outbreak response efforts were done without the need to stand up new infrastructure, but rather were able to utilize existing partnerships across the government and existing infrastructure. What we have done is shifted our preparedness posture, leaning a bit more into some of our near-term preparedness efforts, recognizing this comes at a cost to some of our other activities. Specifically, we have taken some of our existing bulk vaccine material, and filled or in the process of filling it so that it can be more immediately ready for distribution should it be needed. We have also procured small amounts of additional bulk material, amongst other actions. Looking to the future, BARDA will continue to play an active role in the current H5N1 outbreak preparedness and response effort, while maintaining continued work looking to the future at preparedness needs. I look forward to this session with my fellow colleagues and want to thank the committee again for the opportunity to have this important discussion.
Thank you. Dr. Dugan.
Good morning, and thank you for the Bipartisan Commission for holding this event today, and really for the opportunity for CDC to provide a really brief update on our pandemic preparedness efforts for influenza, as well as our strategies and how we're coordinating in the interagency space with federal agency partners, our public health partners, our industry partners, and with our other parts of the government in response to highly pathogenic avian influenza, H5N1. I also want to thank my colleagues here who we've been working very closely with for the better part of 6 months on this effort overall on the H5 response. Since CDC's foundation, really been focused to address the continued threat of not only seasonal influenza viruses, but also those who have pandemic potential. Those are really those novel influenza viruses that emerge from the animal population and can move into people. And this is really a foundational part of our pandemic preparedness effort. And so 2024 marked this outbreak of high-path avian influenza, H5N1, in dairy cattle in the US. It's led to a handful of cases in the US as well this year. In addition to the ongoing infections that are happening in poultry, agriculture, wildlife, other areas, this outbreak is really putting our decades of preparedness efforts to work and to practice and into action. And so H5N1 as a collection of viruses over 20 years is not really a new threat to us, so to speak. We have experience with it. That said, the infection and spread in dairy cows was unexpected, and this is new. And so this is a very new space that we are navigating. We continue from a CDC perspective to be extraordinarily vigilant, to lean in that preparedness posture should this influenza virus evolve to become more efficiently transmitted, not only from animals to people, but of course from person to person. So far, I think we've been very fortunate that all of the cases, as you've heard, have been mild diseases, mostly conjunctivitis, with recovery occurring in all cases in the US. But of course, we know that can change very rapidly, and it has in other countries. There have been fatalities with this particular virus. These viruses know no borders, especially these respiratory viruses. And so they can emerge at any time and really anywhere in the world. We have a number of preparedness tools that help us to be ready from a CDC perspective for combating and being ready for any influenza virus against seasonal or novel or pandemic. And this includes really building that sustaining global and domestic surveillance capabilities. Our laboratory networks are critical for this to really monitor and analyze influenza activity wherever it is happening and whenever it is happening. Developing and deploying diagnostic tests to detect influenza, and then really promoting and delivering vaccines and countermeasures, drugs to really help lessen that severity, as well as those severe outcomes of disease with infection. So these are part of our overall approach, but our core capacities are what we prioritize when we think about pandemic preparedness, and the systems and the tools that we use regularly for seasonal flu also support all of our efforts in preparing for a pandemic influenza. So our epidemiology and surveillance, again, our national system is layered, it's comprehensive. We built it over many decades to detect not only seasonal flu, but novel influenza viruses such as H5N1. And this is what we've seen with the recent case in Missouri. Our virologic surveillance and our laboratories are also very critical. We comprehensively characterize novel influenza viruses from all over the world. We get specimens from many, many different countries as part of our role as a WHO collaborating center. And this informs our efforts to make candidate vaccine viruses, and working closely with BARDA and ASPR to have that preparedness and readiness in that pre-pandemic space. We're looking at genetic characterization, so next generation sequencing, expanding that capacity, as well as that antigenic characterization is really critical. We look at antiviral resistance, as well as looking at the overall risk of any potential viruses. Our diagnostics and testing capacity is also a very critical piece of this as well. Our first line of defense are those seasonal influenza tests that are used in clinical settings. We estimate over about 50 million people in the United States are tested each year in a clinical setting for seasonal flu. And we've got assays that are specific for H5 in over 100 public health labs across the country. And we're also expanding that commercial capacity in our public-private partnerships. And then, of course, our vaccination distribution programs. We work with our state public health partners to distribute millions of flu vaccines annually. So this is what CDC is doing and what we do day in and day out regularly for influenza to really detect and prepare against novel influenza viruses with that pandemic potential. But we know that this takes a whole of government effort. This is really a total government approach to do this work, which is why our current response to H5N1 really involves that close coordination with FDA, USDA, HHS, ASPR, NIH, and BARDA, in addition to all of our state and public health partners, and using that One Health approach to really coordinate and align. So CDC is extraordinarily committed to protecting the health and safety of Americans during this outbreak. And I want to thank you and happy to take any questions.
Well, thank you all for your testimony and your appearance before us today. Dr. Dugan, Dr. Friedrichs indicated that the influence that H5N1 had changed dramatically from 2010 to 2020 and to 24. I wonder if you could just drill down and just tell us perhaps a little bit about what changes you identified in that span. And as part of that question, I might ask, how many, we've seen a growth in the number of species that have been impacted as well. So if you could include that in your answer as well, that would be helpful. Thank you.
Sure, I can start that off, and then maybe Dr. Deeble might want to comment as well on the evolution in the animal space. When we think about H5N viruses, they're a collection of viruses over many, many years. And so there's the biology of influenza viruses, and the way that they're designed is that they reassort, so they swap genes. And this leads to shifts and drifts that have been responsible for many pandemics, at least 4 over the past century or so. And so when we see with the H5N1 viruses, this kind of constant reassortment where they evolve to either become better or less ability to infect wild birds. That's really a wild bird as the reservoir host. But we have seen over 900 cases globally of H5N1 in humans since 1997, when these viruses first emerged out of the wild bird population into poultry to infect people. But Dr. Deeble, I don't know if you want to add anything from the evolutionary perspective in animals.
Thank you. One thing that's been remarkable about this is this particular B313 variant is exquisitely attuned to mammary epithelial cells in dairy cattle. And this, I think, is the most remarkable thing about this particular clade. We've seen H5N1 in mammalian species previously. It's well known in a variety of different species. And even before we had recognized it in dairy cattle, we had some very early reports that we had seen this in some neonatal goats. And so to find it in mammals is not unusual per se, but the way in which this particular variant does manifest is very unusual. And of course, with the exquisite affiliation towards mammary tissue is the high degree of viral load in milk and the risk that that poses to individuals that work directly with dairy cattle.
So I was privileged to represent a district that was very diverse in Southwest Michigan. We had everything, which was wonderful. And I know, sort of like going back on Jim Greenwood's comments when he visited the Antarctica, how he had to, they washed the boots and everything else. I was in the Arctic earlier this year, the same thing, Jim, as we went out on our Zodiac. So when we came back to the ship, we washed our boots as well. But when I went to dairy farms, this was years. I mean, we'd put on special booties. We'd put on the wonderful hairnet. I did that at chicken farms and a number of different places. What are you doing? What recommendations are you doing differently today for the when you find an infected herd? What is the advice or comments that you get? Were they not doing that in advance? I mean, what did you find out?
So it's very interesting because you rightly note the difference in the intensity of enhanced biosecurity practices at poultry facilities versus dairy facilities. And you may recall that when you went into some of those poultry facilities, you would be putting on protective gear. Sometimes you would maybe even been washing in and washing out, depending on the sort of nature of the facility.
Hog farms as well.
Absolutely, very much the same. H5N1 in poultry is devastating. You know, we are talking about a disease with a north of 90% mortality.
That'd be great. Yeah.
Thank you. H5N1, HPAI in poultry is a devastating disease. It has a nearly 98% mortality rate, and which is why the standard practice is to entirely depopulate a poultry farm. And as a result, it is incredibly important in order to ensure that the disease does not make its way onto farms. Dairy, as you probably recall, is a little bit different. It's practiced a little bit more in the open. Cows are outside. It's a little bit different in the way in which they are exposed to the environment. And until recently, and I think it still is the case, that's appropriate because we did not see H5N1 in these dairy cows. I think what we are seeing now is dairy perhaps becoming aware of the risk that H5N1 poses to the herds and beginning to adopt even greater levels of biosecurity in their own farms. Some of that includes establishing a clean, dirty line, limiting the number of individuals who are coming on or leaving a farm, being very strategic about the types of vehicles and equipment movements that happen on farms, limiting the number of trucks and vehicles that are going on and off farms. As we now understand, this disease is principally spread through the movement of animals or through the movement of individuals and equipment from affected premises to unaffected premises. And so we've established some financial supports to help producers enhance their biosecurity. And we're hearing from a lot of folks that they may need some more help. And so we're going to continue to look at the available resources for those producers to see if there isn't something more that we can help them adopt.
The last question I have is, there's an old saying, it's not what you know that counts, but what you don't know that matters. What do you fear the most?
So when we think about it from
Supposed to say I give up. No.
So when we think about it from an MCM development perspective, it's the rapid emergence of a virus that is resistant to currently available antivirals and or is not cross-reactive with our currently available vaccines. That, from our perspective, from the BARDA perspective, we think that development is kind of a worst case scenario for us.
Yeah, I would double down on that and say that really efficient, sustained person-to-person transmission and another pandemic. After going through COVID-19, many lessons learned. That said, we have a very naive population to H5N1. And so we have a very susceptible population to H5N1 based on what we knew right now. So that's what we fear. I think it's what keeps many of us up at night.
Coming from the animal side, I would perhaps add a concern for any increase in virulence within cattle, but also an erosion of confidence of individuals in the food safety supply. We know that pasteurization works very well at inactivating and eliminating this virus. We know that it is not found in animal tissues that are going into the meat supply, so our food supply is safe. But one thing that would concern us greatly is an erosion of consumer confidence in that food supply.
Thank you. Dr. Shalala.
Yeah, your last statement about the erosion of confidence, but ag has for years built a relationship, the question I asked Dr. Friedrichs, with its extension people. They tend to stay in their jobs for a long time. They know the farmers in their area. They transmit the science in a way in which farmers can operate it, but it's also an economic issue with our farmers. So there's a tension there. How do you, what have we learned from that you're using now at the Department of Agriculture?
So the loss of milk.
Could you speak closer to the microphone? We're having microphone problems here.
I think it's a me problem. I think the microphone's fine.
You do speak quickly. Are you from New York or?
I am.
Yeah.
Thank you. Didn't want to say anything with Michigan folks on the dais, but yes. I will be a little louder and be a little slower. The potential that a farmer could lose their access to market is an existential threat. And it is something that every dairy farmer is greatly concerned with. And throughout this emergence, we have been very clear in helping to communicate that having this disease in your herd does not in any way and has not at any point put your market access at risk. That is information that is being shared by folks in Extension Service who you rightly identify as being key stakeholders and trusted partners of farmers. I would also point to veterinarians who work very closely with farmers and their herds who are helping us carry this message about how to address the issue should it come onto their farms, how to prevent the spread of H5N1 onto naive herds, and also to ensure that as we go through this, we continue to learn about the disease. I mentioned USDA is conducting through the NOLN and NVSL lab systems many thousands of PCR tests. And we continue to do the genomic analysis on that to help us understand the nature of the disease. But those extension agents and those veterinarians and those dairy farmers are a principal source of understanding as we do the epidemiological investigation. And from that, we're learning more about how the disease spreads amongst animals within a herd and, of course, between herds.
Thank you.
Dr. Ridge, or Dr. Ridge, Governor Ridge.
You with us?
Yeah, he's back here. Wait, you've got to unmute yourself, Tom. Try it again. No, we're not hearing you. Maybe we'll have to get Dr. Deeble's mic.
Go to Tom.
Tom. All right, I think we'll give up for the moment. Mr. Leader, Mr. Daschle, doctor. Everyone's a doctor today. Go ahead, Tom.
I'll take it. I had a couple of questions. Let me start first of all by thanking our panel and not only for your testimony but your outstanding work. It's really inspirational to many of us who have followed these issues. So thank you for that. In the case of flu, we often hear that seasonal readiness is pandemic preparedness. Can you talk about how the seasonal flu infrastructure has prepared us for the next pandemic and what needs to be done to improve it? I just ask any of the panel members who'd like to take that question.
Sure, I can start with that. Thank you, Dr. Daschle. I think this is one of the central tenets of what really has been built at CDC for the public health infrastructure across all 50 states and the different jurisdictions, that we flex our muscles every year for seasonal influenza because we never know what kind of influenza season we're going to have. Baked into that seasonal preparedness and the identification of viruses, characterization of viruses, specimens coming in, not just from the US, but from across the globe, really also picks up that novel influenza virus. So seasonal influenza A viruses, H5 is also a flu A virus. And so our diagnostics in the public health labs pick up both seasonal and novel. And they're designed that way so that we do all of it together. So every year that we have a seasonal increase in influenza activity, which again can be quite unpredictable, we are also looking for any novel viruses. We're also looking at the severity of all of the viruses, all the flu viruses across the spectrum. And so really to keep that going is really that sustaining those core activities, the laboratory capacity, the sequencing capacity that we've been building, the epidemiology, the surveillance, and helping our state public health partners really making sure that they can do their jobs throughout the year. So flu doesn't stop in the summer. It decreases, but it keeps going. It's still there. And then we also have novel influenza, swine viruses that move into people that we do detect also every year throughout the year. And so really sustaining these core capabilities are really critical for our ability not only to understand what's happening with seasonal influenza, but to be able to detect novel influenza viruses and to respond to it very quickly.
Thank you for that. And that's really a good segue to the other question I had. Your agencies have a very different missions and work with very different stakeholder groups. And we know you all have been working closely together on this response since the spring, but I'd really appreciate it if you could just reflect on what has allowed this collaboration to work well, and also provide maybe suggestions on how we might improve the collaboration looking forward.
I can start. I think one of the really key roles that have fostered the unified coordinated group across the US government has been the existing relationships that we've had. And so CDC, NIH, and the HHS partners meet regularly in an interagency group. We're now meeting every other week, but we meet regularly, usually every month, to discuss influenza, pandemic influenza, seasonal influenza. But we also have a very strong technical and working relationship with USDA. In fact, USDA, our partners there, were the first to alert us of this outbreak in dairy cows, really before I think the full interagency efforts started to coordinate. So I think those efforts to have those relationships built prior to any kind of emergency situation have been very critical to be able to then integrate very easily across the US government and to work together. But I think between ASPR and USDA, we have very strong working relationships prior to this outbreak.
Were you and Dr. Johnson at NAIAID at the same time?
Yes, we were.
Working for Tony?
Yes.
You were.
Could
I would go. Oh,
could I just drill down a little bit on just following up on where I know this is complicated and there may not be a clear answer, but I've got to believe that we've got to find ways to even improve upon the efforts that are underway. And I'd really love your insights on what improvements you think and where they ought to be prioritized.
within the animal health space, I would say that one way in which we can improve response is through more focused and more rapid leveraging of existing relationships with our own principal stakeholder communities. It is probably no surprise that farmers may not be the most forthcoming individuals when it comes to the status of their herd. And they had seen a number of diseases over the years in cattle and did not anticipate this one would be any different. However, with the human health implications, obviously, our index of concern was increased significantly. And so I think going forward, one thing that USDA is going to be focused on is making certain that agricultural stakeholders, and that's not just dairy, but across the full range of species, understand the role that animal diseases can play in human health and continue to expand that understanding and awareness so that in the future, should another event such as this one occur, those folks are more primed, more ready, and hopefully more willing to engage with what is sometimes a disconcerting whole of government response, which to an agricultural producer could seem overwhelming.
That's very helpful. Thank you.
Governor Ridge, we'll try you again. Does your system work?
Yes. Thank you very much. I was just going to add on to the question that Tom Bashel asked and the response we received. You're talking about the Department of Agriculture reaching out to the farmers. What role do the individual states Department of Agriculture have in that outreach and to enhance the surveillance and the education needed by these farmers with regard to this and other viruses? Do you integrate your outreach through state departments of agriculture? What's their role in all of this? You see it. Can it be changed?
We do, sir. We deal with the departments of agriculture in all states and territories and have been having conversations with those state departments of agriculture since the very beginning of this outbreak. Many states play leadership roles in the response within their state's borders. They have the commissioners of agriculture, the state animal health officials, as well as the architecture in order to drive out information and to help collect data. They are often the most trusted individuals within the agricultural community within their states, and we have relied on them heavily for the response. I would say that each state has taken a slightly different response depending on the local authorities that they have, the relationships they have with their farmers, and laws and rules around privacy and disclosure. And so what you have seen has been more robust or more forward, publicly forward responses in some states than others. And as a result, we know a little bit more about this disease in some parts of the country than the others. However, with the federal order, I would like to emphasize that we do have good information across the entirety of the country because that's related to cattle movement. But the way in which the disease manifests is different in different states. We've seen exceptional responses in the early days from the folks in Michigan, thanks to the folks in your state. Certainly the folks in Colorado have to be held up as an exemplar here. And they have successfully or nearly actually, no, excuse me, as of this morning, I believe they've successfully eliminated the disease from the herd in Colorado through robust testing. And now as we've started to see an increase in case numbers in California, we're seeing the state put in additional quarantine requirements amongst their affected producers, as well as working very hard at enhancing some of those biosecurity opportunities and measures that can be put into place, and considering the restriction of movement of cattle within the state in order to arrest the spread.
You know, I appreciate that response. It reminds me of how fortunate I was to have a dairy farmer as my Secretary of Agriculture who had great relationship with his peers throughout the state. But to that end, have either of you been ever invited to both Republicans and Democrats have a national conference and they invite speakers? Have any of you been invited to talk about this at a state level? I mean, it seems to me that early detection would require an awareness capability at the state level, even among the governors, to appreciate and understand the resources that you have. I would encourage you to that's something maybe we could do, Chairman Shalala, to encourage our friends at the Republicans and Democrats Governors Association, given the widespread impact this has on health and the agriculture industry, to encourage them to invite some of these speakers to participate in their annual forums, just to give them a heads up on what's going on, to be mindful of the resources available to help them identify it and then deal with it. So I thank you for your testimony and for your service.
Before I yield to Jim Greenwood, let me just ask a little bit of a follow-up. So as I'm thinking about the state organizations and farms, state fairs, all of a sudden you've got, I don't know, maybe I've got some big county fairs, maybe 100 different farms that are involved that'll coalesce in a certain county. What type of testing or advice have you passed on to the county fair boards?
Yeah, I'll leave the enhanced PPE discussion to my colleagues, but within the animal health space, we had longstanding recommendations about pre-movement testing of animals to state fairs. And with the emergence of H5N1, we've seen almost every state implement, if not just those guidelines, but enhanced guidelines. Most fairs this year required pre-shipment testing of animals within 1 to 3 weeks prior to movement. Many fairs did not show lactating dairy cattle in an effort to reduce the risk to the other animals that may be present. And we saw widespread information dissemination about the types of safety practices individuals could adopt in order to keep themselves and their animals safe.
Thank you, Dr. Deeble. Just to add to that, I think every annual fair event for us from a CDC public health perspective is an opportunity to, of course, message, about swine influenza and other influenza viruses that may be present to any fairgoers. It's a really important part, I think, of many people's summers and what they look forward to each year. That said, I think we really made sure to work with the state public health departments and the agricultural sides of the state support systems to really make sure that we had guidance for across the board that was updated, not only just for swine and poultry, but of course now in cattle and dairy cows. So we were updating that guidance. We put that out in advance of the state fairs when the kickoffs were starting. And also really I think many of the states are working with their agricultural counterparts to get more tailored guidance for their specific fairs, depending on when their fair season happens. So I think that's been a really important point that we worked with USDA early on to think about this and to, again, collaborate in that space so that everybody was on the same page.
Thank you. Jim Greenwood.
Thanks. This is a question I'd like to pose to each of you. And it's a somewhat complex question, but I think it's a critical one. And it is thinking about the course of this virus over the next 5 to 10 years. What would you define as the worst case scenario that we could be looking at 5 or 10 years from now? And what would you consider to be the best case scenario 5 or 10 years from now? And what are the things that will have to happen both within and beyond the scope of your agencies to maximize the likelihood that we end up with the best case scenario? You have 10 minutes to prepare your answer.
Oh, yeah. So, I think from my perspective, the worst case obviously is a full spread pandemic of H5 with, relatively high rate of lethality.
In the human population?
Sorry, yes, in human population. Again, being focused on human medical countermeasures, from my perspective, that is the absolute worst case. And I think the best case that we're looking at is one where we have, we do not have an outbreak. We certainly don't have a pandemic, but we have the tools ready. The ones we have now, but built and even that enable an even faster response if we do need it. And so I think that's from my perspective, as I look at it, that's where we hope to be in 10 years is certainly a better spot than we are now. And then, like I said, that worst case is the emergence of a virus. Again, as I mentioned earlier, particularly one with high lethality, spreads rapidly, and it's able to evade our current medical countermeasures.
I would say our worst case scenario very much tracks the same. USDA is a One Health entity. We care very much about the health and welfare of everyone as well as our animals. So I can't imagine a scenario worse than the one that's laid out here. Best case for us looks like enhanced biosecurity being adopted at more and more facilities, and through that, the eradication of this disease from the national herd, with greater understanding, decreased risk of transmission from dairy facilities to poultry facilities, and ultimately, as I had mentioned, a priming of farmers so that they understand the potential impacts of the disease that they may encounter in their own herd on themselves, their workers, and their communities. I'd also mention here that an effective vaccine is a possibility, and that would certainly contribute potentially to the decrease in the degree of virus that may be shed or the degree of transmissibility either between animals or between animals and humans. And we, of course, would love to see that happen as well.
Yeah, I would just add that, of course, worst case scenario, not only that increased severity, widespread pandemic situation, which again has impact economically, agriculturally, and so many factors, very similar to the COVID-19 pandemic, but even more severe, or a virus that's behaving in a different way, something that we are not used to seeing. I think the concern for us is really that person-to-person respiratory rapid spread, that efficient transmission. But certainly there can be other ways that clearly influenza viruses are presenting, like conjunctivitis, which is not completely surprising, but it is a little bit more than what we would expect to see. So that's probably the worst. And then just doubling down on the eradication as the best case scenario. And again, those lessons learned. This is a global virus. This virus has been circulating in wild birds and animals. And so I think there are a lot of things that we can learn from our experiences that can help drive the global agricultural and public health community from a preparedness perspective and understanding the impact of this particular H5N1 virus on the diversity of other animals that are out there, because I think that's clearly a very important point where the impact is quite big on the species.
Is this virus always going to be with us, or does it, I mean, is it one of these background viruses that just always be there and we have to mitigate against its effects, or does it go away somehow? Like in March?
Question. I mean, I'm not a bird immunologist. I don't know, Dr. Deeble, if you want to take a stab at that one. But I think these viruses tend to cycle. There's the biggest diversity of avian influenza is in wild birds as a reservoir host, but I don't know. Eric, you wanted to add to that?
I believe it was 1872 when we differentiated avian influenza from fowl plague, which was a general catch-all term to mean every bird disease that we had. So this is a disease that has probably been with us for all time. The way in which it manifests changes, as Dr. Dugan has mentioned, and that is of great concern and is necessary for us to continue to investigate and continue to be vigilant. But yes, this is a disease that has likely always been with us and almost always will be. This particular variant, B313, need not be with us forever. I do believe that we can eliminate this one.
Thank you very much.
Dr. Parker.
Yes, thank you. And thank you for your witness and actually the demonstration of interagency collaboration. It's great to see. And so maybe I do have a couple of questions real quick, but first, Dr. Deeble, I really thank you for acknowledging some of the challenges of just the need to educate the commodity groups and to bring them along. You can't just, force fit something, that you need to really bring them along and encourage them to participate. And I thank you for doing that. But the first question is, it seems, and you mentioned that 3 states are actually doing a pretty good job of aggressive testing and so forth, but we're also seeing, I think in California, some reports that maybe the disease is more serious than we originally thought in dairy cattle. Is that really a reflection that it is getting more serious in dairy, or are we just seeing it because we're testing more in these states?
You raise a good point, and we continue to learn more about this disease every day. And I have to hold up the folks in California as doing an exceptional job with their response to the disease. I think one of the things that we may be seeing is the impacts of heat stress on dairy cattle. It's been extraordinarily hot in the Central Valley, and we know that some of the cows that we would expect to recover well, perhaps in a cooler place or perhaps earlier in the year, are needing significant rehydration therapy as well as some additional medications. And so we don't know, but we are learning, and we're in daily conversation with the folks in California so that we do have a better understanding.
Thanks. And then maybe one quick question, maybe for all three. What would be a trigger point that says we need to ramp up our response and maybe go into a new phase, whether it be in dairy, cattle, poultry, or humans?
From the human perspective, I'll jump in. Changes in severity in multiple cases, clusters all happening concurrently, changes in the virus. That means that it's evolving to avoid our countermeasures. Those are kind of some high level triggers that I think we would certainly act on.
I would say on the animal side, some evidence of respiratory transmission between animals. At this point, we are not seeing that, or increased prevalence of this particular variant of the virus in wildlife species, which we are also not detecting at this point.
I have time for one more question.
Sure.
So
Yep.
I'm really encouraged by the research agenda that was just announced, and actually that includes vaccine research for animals, poultry, and so forth. Any idea of how maybe BARDA and USDA may collaborate on the research agenda for vaccines? Or is it completely kind of separate? USDA would do their thing and BARDA would do their thing for the respective human and animals?
So not so much we do our thing, they do their thing, right? It's, the basic vaccinology is known and it's the same. I won't speak for my USDA colleagues. We initially, had some meetings, some discussions, laid out kind of what we do, they laid out what they do. And, the manufacturing process, the approval process are separate. And so, we have good alignment, we understand, and the general approaches. For us, we have our commercial, license process that we use for USDA. They're starting a little bit different spot, and so we keep in touch. But they have their kind of path, and as they generate data and stuff, we have some touch bases to see. But I don't think there's more that we could do to support at this point. I mean, they're fantastic scientists. They understand how to develop vet vaccines, and so I think they're have it well under control.
I'd say recently the Center for Veterinary Biologics put out a notice that essentially created a pathway for individuals or entities that are interested in manufacturing a vaccine to begin conducting field safety trials. We've had a really robust response. We've got 6 or 7 folks that are in the process of providing submissions to CVB for approval for these field safety trials, and we expect to be able to begin approving those very shortly.
Very good. Thank you.
Any other? Go ahead. I think we have time for both of you.
Thank you. Thank you, Representative. And I would just want to thank former colleagues here for their continued work. All of you and your agencies are just doing vital work. I know from the very first February 2022 indications in bird populations and in commercial farms that this outbreak was going to spread. And so first, I just want to start with thank you, because I think it's hard to do the work you do. And I've seen it firsthand, having been on the National Security Council. I want to talk about farm workers and what we could do to further protect them. We know that in every outbreak, risk is not equally distributed. Farm workers in this outbreak, as you've already noted, are at higher risk than the general public may be for this virus. By lowering their risk of getting sick, we lower our shared risk of this H5N1 outbreak turning into the next pandemic. There has been at least some news reported that there are deliberations around potential for vaccinating that higher risk group of farm workers. I don't want you to push you to get ahead of any deliberations you're having internally on that discussion or on that decision. But I'd be curious to ask 2 related questions. One is, how important is a seasonal flu vaccination campaign? Building on Senator Daschle's point, you spoke, Dr. Duggan, about flexing that muscle on seasonal flu. We have outreach to other high-risk groups, pregnant people. We have high elderly, those with comorbidities. Is there a concerted push on seasonal flu vaccination for farm workers? And how does that, of course, I know as a physician that won't stop H5N1 itself, but it could reduce the risk of co-infection and reassortment between the regular strain. Although that risk I know is probably low, it's probably also hard to fully quantify. But there have been situations in the past where a regular seasonal flu vaccination campaign can set the platform for ramping up a pandemic flu vaccination program should we need it. So what are we doing now in terms of seasonal flu vaccination outreach? And the second part of this is just how much do state policies complicate that effort? If you look at the Department of Labor's reporting, half of farm workers are undocumented. And if you look at KFF's reporting, Kaiser Family Foundation, half of undocumented people in this country are uninsured. I think of the states that have dairy cow outbreaks, there's just a very small number. Looking at Colorado, for instance, that provides any kind of Medicaid or state-funded coverage. Is that going to complicate your efforts to potentially increase vaccination uptake amongst farm workers?
These are very excellent questions and really good points. So I think there are a couple of pieces to this. When we do think about the overall risk, different activities on different farms clearly have some different levels of risk associated with them. And so in our epidemiologic investigations and working with our state public health partners who lead these investigations, California, Michigan, Colorado, we are trying to tease out more particular activities on those farms to then kind of update what is the risk higher for those who are in the milking parlor or those who are, again, processing milk, that piece of that. So we're using that to update interim guidance documents that we can to really better inform all of the, anybody, farm workers, related farm workers, veterinarians, other people who have those interactions with any infected animals. That said, when we think about farm workers and protecting their health, that's one of our again, central efforts in this space. And so it's really of a multifactorial approach. Number one, we're partnering with the National Center for Farm Worker Health. That's a really key organization that we have a cooperative agreement with as an agency perspective. They can reach community-based organizations that can really, again, build those partnerships and those trusted messengers so that it's not necessarily a government official, whether it's state, local, or federal, providing the information or being that messenger. It's trusted partners who have those relationships that have been built over many, many years with farm workers and their communities to, again, get that information out, making sure they have awareness, understanding, know where to get any kind of care, and then supporting that effort in the state and local epidemiologic investigations, the monitoring for individuals that have been exposed for symptoms for those 10 days or longer, making sure that, again, those partners are around and available to explain how to get a test, where to get a test, is treatment available if, again, they have any kind of symptoms. So that's one piece of that. The other piece of that is, again, lowering the barrier to care. And so one of the things we have been doing is we did have some funds available to try to lower the barrier to seasonal flu vaccines for farm workers. We know that this is not a population that regularly has high uptake of seasonal flu vaccines for a number of reasons. And so by making funds available to the states, we can actually provide easier access to seasonal flu vaccines to rule that out. We know seasonal flu is coming. We know that it causes significant morbidity and mortality every year. We can at least try to dampen that morbidity and mortality in a group, again, that may not have easy access to care. We can at least try to reduce that.
Funding is being provided now to the states to do it, and is it in the levels that are needed, or how do you?
So the way that it works, and we can certainly provide you more detail, is that funds were made available for states to apply for additional seasonal vaccines, again, for particular groups, and then to get either support, not just for the purchasing of vaccines. So we purchase vaccines and then are available to the states that are impacted with H5N1 and dairy cows. And then there's also funds that were available to implement those vaccines, whether it's ride shares or mobile clinics. So, and again, that's kind of a piece of that, but we can get you more details.
Thank you. Well, thank you all for being with us. Very, very enlightening testimony, and we look forward to working with you in the future for sure. Thank you. So this panel, before we break for lunch, I'm very pleased to announce that from the great state of Michigan, Nora Wineland, who's the state veterinarian, Michigan Department of Agriculture. We have Mike McCloskey, founder and chairman of the Fair Oaks Farms. What state might I ask? Is that
Indiana,
Indiana? Great. And
close to Michigan.
yeah, close to Michigan. And Gerald Parker, Associate Dean, Global One Health College of Veterinary Medicine at the Bush School of Government and Public Service, Texas A&M. Dr. Wineland, pleased to have you here. Thank you.
Thank you. Thank you for the opportunity to come and speak before this great group. So Michigan had our first case of HPAI in dairy cattle in late March, after a rather quiet winter and what has now been an extended outbreak of over 2 years duration. Prior to the March detections, we had been able to handle our response locally with our state and federal resources in the state of Michigan. As you know, we were among the initial group of states to have the dairy cattle B3.13 detections announced. On April 1st, I received a call from the veterinarian for one of our larger poultry facilities, indicating they were experiencing high losses in one of their barns. We immediately activated our incident management team and quickly realized we would need more help than our local team could handle and asked for support from the USDA color teams. As more dairies reported sick cows, it was also clear that we needed more resources to work with these herds and do everything we could to better understand the epidemiological picture so we could take measures to stop the movement of this virus on the farms, between the farms, and from dairy to poultry, as we quickly learned. We requested a USDA epi-strike team to come in and help with the on-farm investigations in addition to the USDA color teams. With more poultry farms also reporting in with sick birds, having the USDA color teams to support us was immensely helpful, as we had a lot to navigate that was all new. From navigating the USDA requirements for concurrent depopulation of multiple large facilities, where in some cases the producer did the work, and in other cases, the national stockpile resources were ordered and employed. Sometimes payments were a flat rate for the producers to do the work, and other times they were approved on an item by item basis, and where disposal had to be completed in a biosecure manner that involved movement of materials to different types of offsite locations. While there is a red book that guides responders for these types of situations, there are many site and state-specific needs that must be navigated, and we are very grateful for the support of USDA as we did that. On the dairy side, there's no red book. More unknowns than knowns when we first were faced with the need to respond. The support of the strike team and others in USDA has been invaluable as we navigated those first days and weeks. We had regular calls with USDA as well as locally with our industry, both poultry and dairy, public health, practicing veterinarians, and many others. We have a lot of lessons learned from those experiences, which will have us better prepared for any future events. At about 2 weeks in, we assessed the situation based on what the strike team had learned. With no clear transmission path determined and with continued detections, improving biosecurity was our best hope. The Secure Milk Supply Plan became the basis for our state order, which went into effect on May 8th and required both dairy and poultry operations to implement enhanced on-farm biosecurity. Specifically, we asked that they designate a biosecurity manager if they didn't already have one, maintain a visitor logbook, and as others have mentioned, have only necessary visitors come to their farms, establish a line of separation with clear procedures for cleaning and disinfection when crossing that line. The order also had things to say about both poultry and dairy cattle exhibitions that were tied to the disease status in our state. We elected not to quarantine dairy farms. Factors that impacted this decision included no clear science for how we would release a quarantine, know that a farm was clear of disease, producer reluctance to report if they knew there was going to be a quarantine and they feared that that would mean daily movements that are necessary on a modern dairy would not be allowed. Movement of calves to offsite rearing that happen on a daily basis. Movement of dry cows offsite until they're ready to calve again and rejoin the milking herd, and movement of replacements into the milking herd. All of these things are happening on our farms every day. With all of the unknowns, our goal was to learn as much as possible about the disease and where it was, so we could take appropriate steps to protect human and animal health. To do this, we needed herds to report and a team to learn from those reports. The Epi Strike team provided that initially, and we are transitioning to getting continued support from a team of epidemiologists at Michigan State University. We still have more questions than answers, but progress is being made on that front, which is allowing us to think ahead on how we approach surveillance to determine if the disease is still in Michigan or if it has moved on. We're also looking at how best to address the ongoing need for vigilance and biosecurity on our farms to protect both public and animal health. Again, thank you for the opportunity.
Thank you for your work. Mike McCloskey, welcome.
Thank you. I really appreciate you having me here today to share my experience with the disease so far in dairy cattle. I am a veterinarian with a specialty in food animal production for the University of California, Davis. Practiced many years, became a dairy farmer. After that, I established a milk cooperative known as Select Milk Producers, which I founded and was the CEO for 25 years. The presence of our dairy farms are basically in the Southwest and the Midwest, which is where the disease had its beginnings in the Southwest, as we know, and then moved to the Midwest. So I had some intimate relationship with many farmers, colleague farmers that were involved in the early stage of the disease. So I look forward to sharing some of those experiences through your questions. I also look forward to sharing biosecurity, vaccination, and other scenarios as I see them on dairy farms today and moving forward in the presence of the disease. And I also look forward to sharing my impression of how the work got accomplished initially and the relationship between the different agencies from a federal standpoint of view, from a state point of view, from the dairy farmer and the employees of the dairy farmers. I yield my time for questions.
Great. Dr. Parker.
Secretary Shalala, Governor Ridge, Senator Daschle, Representative Upton, Representative Greenwood, Dr. George, and my ex officio colleagues. Thank you for the opportunity to appear as a witness today to answer any questions you may have, and I'll try to do that to the best of my ability. I am Jerry Parker. My comments today are my own, based on experience in biodefense, pandemic preparedness, and health security. My opening statement will take a theme of sharing lessons observed, but not always turned into lessons learned that inform my recommendations. As you know, I'm not a stranger to the Biodefense Commission's policy, research, and recommendations. I'm especially proud of the Commission's first report, A Blueprint for Biodefense, published in 2015, where the importance of an effective leadership structure and national biodefense strategy were highlighted as essential to drive effective collaboration, coordination, communication, and innovation over the long term. That recommendation led to congressional requirements to establish what became the 2018 National Biodefense Strategy. The Biden administration updated the strategy with the 2022 National Biodefense Strategy and Implementation Plan and the National Security Memorandum 16, strengthening the security and resilience of the United States Food and Agricultural Defense Strategy that harkens back to the original HSPD 10 and HSPD 9 from 2004. Importantly, a One Health approach was woven into the fabric of the 2022 plans that was lacking in previous biodefense strategies. But was One Health effectively implemented in the current crisis? Were economic and agricultural trade implications accounted for? Subsequently, the Biodefense Commission recommended in the 2024 National Blueprint for Biodefense that federal governments develop departmental implementation plans tiered to the White House plan and agricultural defense strategies. Maybe those plans were in place, but our experience with with the 2024 bird flu crisis tell us that we could have benefited from better integration in agile plans that can better respond to surprises tied to a singular budget that can also manage inevitable public health and economic tensions and trade-offs. My colleagues just described how difficult the early days were, especially for the agricultural commodity groups. The latest response to bird flu highlights One Health policy gaps that require coordinating and collaborative approaches in the executive branch through state and local authorities and the commodity groups, as well as above and beyond what any given congressional committee of jurisdiction may be able to achieve alone, meaning the health and farm committees will need to work together to close legislative and appropriation gaps. Speaking of legislation, lessons observed were also gleaned from the Pandemic and All Hazards Preparedness Act, first authorized in 2006, reauthorized in 2013 and 2019, but as you know, has not yet been reauthorized in this current cycle. The history of PAPA is relevant to the understanding of policy gaps that we continue to encounter in contemporary all hazards and infectious disease crisis. For students and scholars of PAPA like me, new medical and public health organizations and programs were first authorized in 2006. But PAPA did not then and does not now enable an effective One Health approach that is essential to most all hazard threats we face today. It takes people in the field like my colleagues on this panel that are on the front lines responding to bird flu to work toward that goal despite national policy and funding gaps. Regardless, the initial PAPA legislation provided useful lessons learned to consider today. First and foremost was the importance of leadership and leadership structures that can maximize use of available resources. This cannot be overstated. We do not have unlimited resources. We must maximally utilize all available resources. As you know, congressional leadership was provided by the late Senator Kennedy and the Senator Richard Burr. It was truly bipartisan, like the Bipartisan Biodefense Commission. There may be differences in how to accomplish shared policy goals, but those were always worked out through respectful dialogue and negotiations and collaboration. And it was clear that the original PAPA, there were clear requirements that led to that original PAPA, like Hurricane Katrina, like the anthrax letter attack, like SARS-1 in 2003. And today, the pandemic and all hazard threats we face are much more complex and intense. We must reauthorize PAPA. Third, H5N1 bird flu was also a motivating factor for PAPA back in the day. And we've already talked a little bit about that. But in fact, President Bush in 2005 requested an emergency supplemental of $6 billion to combat H5N1, which was considered a pandemic threat at the time. That was unprecedented for public health preparedness. And in that plan, in that strategy, there were actually very clear milestones, metrics, and 400 action items that we were responsible for accomplishing in that plan. That plan was important to the president, it was important to Congress, and we were held accountable for accomplishing the metrics in that plan. Today, is pandemic preparedness the same type of priority? I'll leave that as a question. So anyway, I encourage you to look at that 2006 National Strategy and Implementation Plan. There may be some lessons learned that we can apply to the current pandemic preparedness needs today. But let's look forward to the bird flu response today. And so the situational awareness and path forward. First, this is a large outbreak in dairy cows. It was unusual and not anticipated in our response plans. The situation in dairy cattle has evolved rapidly since it was first recognized in March 2024, expanding to 14 states and close to 300 herds of the state. The current risk assessment to the public remains low, but moderate in occupational health exposure settings. Even though the current risk assessment is low to the public, the time to transmission to a pandemic-capable virus, which is widespread, may be short. It is difficult to predict if the virus will acquire the capacity for human-human transmission or when, under what conditions it would make that fateful leap if it does. But continued circulation in new mammalian species may increase the likelihood. I, along with my public health preparedness colleagues, are concerned the risk assessment assessment could evolve rapidly. I'm also concerned that bird flu impacts dairy cattle more than we originally thought after some states began to adopt more aggressive testing strategies. There have been response challenges to the current crisis. There will always be response challenges in any new crisis. So that is not a surprise, but how we respond to those challenges can dictate success or failure. For example, public health had little experience working with dairy industry and vice versa. Well, unlike their hard lessons learned working with the poultry industry. Another lesson learned, even from COVID, we must acknowledge that public health objectives may not necessarily be aligned with economic objectives and vice versa. These tensions will occur. We have to learn how to manage these tensions. Finally, excessive finger pointing is counterproductive. We must move on to solving the problems. Going forward, we should have a flexible national response plan that incorporates stakeholders at all levels in government and the private sector. I would recommend 4 primary objectives for a national plan. First, we must establish trust and work toward common goals, which should include both the prevention of human H5N1 cases and preservation of the dairy industry. Number 2, develop operational objectives that are community across response tiers and sectors. 3, ensure that the dairy industry has a prominent voice in planning and discussions. And number 4, share data in as transparent a manner as possible while simultaneously acknowledge privacy concerns that exist and must be honored. The overarching goal of a national response plan must include protect human health, protect farm and milk processing workforce, protect animals, and protect the food supply. The response plan should incorporate the following elements: trusted relationship across all segments, integrated infectious disease surveillance for humans, cattle, swine, poultry, birds, wildlife, and other mammals, a common operating picture through active monitoring so authorities, the private sector, and public knows what is happening in near real time. It all comes down to the basics: collaboration, coordination, communication, innovation at all levels. It sounds easy, but it's hard to implement in practice. In closing, I just want to say that one, I'm very happy to see that HHS has increased investments to expand the pre-pandemic vaccine for H5N1. And I'm especially pleased to see that the research agenda that's in coordination with USDA and HHS has been released. That, in fact, that research agenda is very comprehensive, and it reminds me of the comprehensive scope of that 2006 National Strategy and Implementation Plan in its scope, and also to focus on reasserting some U.S. leadership in this space. So finally, achieving the strategic alignment, including budgets across agencies, crucial for an effective influenza and medical response from NIAID to BARDA, USDA, and DoD for the procurement and deployment of medical countermeasures. We must establish clear, coordinated roadmap that integrates budgets across the entire biodefense enterprise to optimize resources and make it clean and navigable for all stakeholders. Thank you.
Well, thank you all. You know, the word trust has been used, I think, by every panel this morning. And we've talked a little bit about puns. And I just have to believe that you're the owner of one of these large dairy herds, and you know, that's your life and soul. I mean, you're working 24/7. It's an unbelievable industry in terms of the work that needs to be provided, different issues that are there that are confronting you. And all of a sudden the word holy cow, maybe something else than cow, comes up if in fact your herd is identified as a problem herd. And so, Dr. McCloskey, I just, you know, what concerns do the herd owners have? I mean, what kind of trust is built in? Is it the fabric of the Farm Bureau, which is, I believe, is an amazing organization? Is it the relationships with the state veterinarians, the interaction that they have? What's the chatter among the crew of folks? And they all know each other, and they all work together. They know what the marketplace is like, and it's like, oh man, what are we going to do now?
Well, that's the excellent question, and one of the reasons that I wanted to be here today. So thank you for opening with that. First, let me say what many have said, that everyone from the federal agencies to state agencies to local veterinarians, dairy farmers, and even employees, I think everyone is aligned and has the best intentions. And And I saw that firsthand. I got to talk to the CDC, I got to talk to USDA, I got to talk to local state veterinarians, and obviously I have many dairy producer colleagues who I've been with in business for many, many years, who are cooperative structure, who trust our relationships and have shared deeply with me their concerns. Unfortunately, I want to, just for the record, make my herds have not been infected, by fortune, but again, many of our colleagues have. So with that said, I was disappointed that that trust issue became an issue, and it's been said here today also that we have to start at the dairy farm level and work our way up. And that starts with the veterinarian. Truly is the most trusted individual that consults onto these dairy farms, has a great relationship always with the state veterinarians. So I believe just that sequence, that laddering up from the dairy farm to the state, to their veterinarian, to the state veterinarian, to the relationship of the states with USDA and the relationship with CDC from there. There was a disconnect, in my opinion, of the different interests that a CDC individual would look at it as a human case, and really that's their concern, and I respect that and understand that. But to get yourself in the head of a dairy farmer, as you well described a second ago, it's difficult because each one has their responsibilities, and we really need to focus as a country to get down into the farm level through this laddering up and truly understand how do we build that trust? Because I as a veterinarian, my number one responsibility is to be able to make sure that zoonotic diseases are very much vigilant over those and protected for not infecting humans. And it was difficult to see a level of concern that farmers would have about what will happen to this information, where will it go, and that trust was not there at that moment like it should be. Now, I just got to commend everyone, because in spite of that, all the agencies have come together, have worked incredibly hard, and the data that has been developed in this short period of time becomes very beneficial for us to understand this disease so much better. But I would have desired to see a more seamless relationship, and I ask you to please, on a post-mortem of all of this, is the biggest focus has to be that we as an agriculture industry have to figure out how this becomes seamless as we see diseases as severe as this one that can affect humans in the way that it could. And we as animal producers need to be part of that solution and work with every agency, but we have to build that trust. So from the moment Senator Daschle and Dr. Friedrichs and others here have said, trust is number one. I cannot agree more with that. And I encourage that we look for that way. Again, I truly believe it's through the veterinarians, through the dairy farm veterinarian or the poultry veterinarian together working with state, because there is that friendship and relationship of those producers with their Department of Agriculture from that state. And there is a relationship with the state veterinarians. And that's what we got to build upon to get their support and then work from there to the federal agencies.
Well, thank you, Dr. Weiland. I'm only imagining or guessing that with poultry, it's a much quicker knowledge to farm that we got a problem. Dairy might be hidden for a longer period of time, but I don't know that. What type of warning signs did you see coming from the farms? How quickly, in general, what was the rule of thumb before they might ask for help? and how, knowing that Michigan has a great relationship with Michigan State University in terms of ag research, what are they doing in response to the issue that we had and have in Michigan?
That's a whole lot of questions.
I know, and that'll be my last one. Be Dr. Shalala will be next.
I'll try to start with where you started. So obviously the call that I got on April 1st, the poultry were very sick and very quickly sick. I think on the cattle side, there were rumors back in February and March about this happening in the panhandle of Texas. I was at actually a USAHA government relations meeting with several of my other state animal health official colleagues, and there was much talk of that in mid-March, like, what is this that's going on? So it had a very insidious presentation. I will say that our particular first herd, our initial herd, animals left the state of Texas and they were clinically normal. 2 days later, that herd broke with signs. And then 10 days later, 12 days later in Michigan, those cattle broke with signs. So we're talking about a prolonged incubation period. In some cases, we have had farms that have had no change in production parameters. So their somatic cell count, their production levels have not been out of normal. They haven't been pulling extra cattle into the sick pens. So everywhere from that to 50% of the herd affected. So it's been highly variable. So to speak to what Michigan State is doing, so USDA helped coordinate a longitudinal study to watch how this virus is moving on the farms to understand how it's spreading between cows. And Michigan State has been very instrumental in working with us in getting those samples, getting teams out on those farms to collect them, and then running them at the veterinary diagnostic laboratory. So it's been truly a great partnership in very trying times.
Thank you. Dr. Shalala.
I wanted to establish my credibility. I'm the only government official that ever did a Got Milk campaign, Milk Mustache ad. I should point out, over the objection of the ethics officer and the general counsel of the Department of Health and Human Services, I want to pursue the seamless idea, and who can do that? Can the state veterinarian make this seamless for the milk producers? I'm always committed to a bottoms up kind of approach, and I have great confidence in states and in agricultural extension agents and all the people that work with America's farmers. And I have to point out, I was chancellor of the University of Wisconsin in Madison, so I had the land grant. I know a lot of dairy farmers.
Cheesehead was what we call you.
Yeah. He's got very good cheddar. Dr. Wyland, do you want to start?
Sure, I can start on that one. So I think, practicing veterinarians out there are the eyes and ears for us when it comes to zoonotic disease detection, understanding what's going on out in the population. So Dr. McCluskey is exactly right that we need to start there. And the dairymen have a good relationship with their veterinarian. So in our state anyway, and this has been pointed out, it varies, but anyone who has reason to believe that they might have an infectious, contagious, or reportable animal disease has a duty to report. So farmers can report, veterinarians can report, but we need to hear from them, and they need to feel comfortable that the response that we have as regulators is not going to be worse than whatever it is, the disease they're going through. And I think that was one of our principles maybe that got more cooperation initially with getting those reports. But to the seamless, I think that's hard as you're going into a new event. And we did a lot of outreach to try and help let our veterinarians know what we knew, which was more questions than answers. But I think you make a good point.
Dr. McCluskey, you seem to have created the seamlessness because you talk to the CDC, you talk to the Department of Agriculture, you talk to your state veterinarian. Can you answer that question too? How would you create the seamless? What kind of structure would you put together?
I agree with Nora that it is at the dairy farmer level that we need to build the trust, and the approach through their veterinarians and through the state is the way we have to do this. But we got to engage them, because we're not engaging them to create that seamless. So the herd veterinarian needs the support of the engagement from the state to work with their farmers and is this through meetings or through what, but something has to be done to work with farmers for them to understand the importance that now that we have diseases like these, that their obligation to report is safe. And safe is a word. If we can't get the point across to farmers that their obligation to report is safe, it is a problem. I am going to share with you something that occurred just last week regarding this disease. And it's a letter to one of my farmer colleagues from USDA. And it is letting them know that FOIA has been applied to their records of this disease, and they have 7 days to answer this particular letter to see if they are going to oppose the release of this information. This letter is by email. It is not a secured receipt. It gives 7 days to a farmer to make a decision, which he may not or even understand what any of this means. He needs to go to an attorney. He needs to figure this out. He needs to break his routine. This individual participated in the process of this disease. Unfortunately, this situation now is spread amongst all my colleague farmers. And they're going, well, wait a second. 7 days to respond. If not, your information gets released. Maybe it was by email and I didn't even check my email for whatever day. I don't know. But these things don't build trust. All the contrary, they break them down. And it's a big concern to me when this came up just recently. So it's a harsh example, but I'm here to share it with you because it's out. Every dairy farmer in the country today, it's being shared at every coffee shop about, should I open my doors and share my information? I don't know. So how do we build that trust? These are the things that are very concerned. We mentioned our employees. I mean, a lot of them are from foreign countries. When they see people walk onto their farms in white suits, that's a big concern. So these are the things that we have to sit down and talk together. This is so serious. That's why I took my time out to be here today. We have to sit down at this level, at the state level, with state officials, local veterinarians, and farmers, and have these discussions. How are we going to make it safe for them in their businesses? You shared very eloquently what goes on most farming practices. Farmers have to run a business like everyone else, and then they have the risk of weather, and animals do get sick. So add those two elements to a business that's already complex, like any other business, you're dealing with very, very difficult, hard work for a commodity pricing system. So we got to get in their minds as that whole chain from federal all the way down. We got to get into the farmers' minds and figure out how are we going to make him feel comfortable and safe, because he has an obligation to share, but we have to help him meet that obligation.
Dr. Parker, do you want to add anything?
No, it's just, that trust is fundamental. I can't really add to what Mike is bringing, the true ground truth and the trusted relationship. And it does, as you said yourself, that trust it starts at the bottom up to work on that. And I think, one of the real challenges here with the commodity groups and with this surprise, this surprised all of us with H5N1 going into dairy cattle. We didn't anticipate this. We didn't plan it. It wasn't part of our plans. The dairy farmers didn't know what the regulatory hammer was going to be. And so this is just a very, very complex situation, and it's hard to build trust during crisis. That we're gonna take the time to somehow work on that bottom up building trust. And land grant universities do have a role to play in their trusted relationships in the communities that they serve.
Thanks. Governor Ridge. You got to find that unmute button. Testing.
Hope we are okay now. Thank you. How important that element of trust is. I have to acknowledge a huge mistake I made as a young congressman. We have a substantial number of dairy farmers in northwestern Pennsylvania. I got a chance. You did the ad on drink milk, Madam Chairman, but actually milk some cows the old-fashioned way. And I had a gathering of dairy farmers together, and major faux pas. Guess what? You appreciate this. I had artificial creamer there rather than real stuff. You know, there's little.
I sympathize with you, Governor.
It took me a while I think I ultimately earned their trust, but I learned the hard way. So anyhow, very informative. And I might ask, is there a series, a template of biosecurity measures that you would like to see all farmers adopt as they operate their business?
Could I answer that?
Please, I wish you would.
Yes, thank you. So there cannot be a one fits all, unfortunately. So let me share with you. I think that's very important. It's been discussed a little bit here today. Is that if you look at poultry farms, it is easier to go to a poultry farm and apply biosecurity. Let's just take with the migratory bird issue. We can enclose, we can net, we can do things that can truly increase the protection. Well, let's put it that way. Well, we look at our dairy farms today, and the infrastructure in our dairy farms is one that's open, as was shared earlier. And especially the feed area. Our feed areas are very, very open, and we mix our feed and then, move it to the cows and bird excrement and all feces, and all sorts of, even animals, small birds that have died could get mixed up in this feed because you're pushing feed with large loaders and moving it around and taking it to the cows. The barns are open. Birds are being able to get in there. So to change that infrastructure is a monumental expense that I just don't see it happening. A lot of these farms still have 20 years of investment left, their lifespan, and they're not going to change to that level. Of a hog farm today is totally enclosed, ventilation is controlled, so it's a lot easier to manage those. On dairy cattle, we have maintained them a lot more open than others. So the biosecurity measures are going to have to be very different applied from farm to farm. Also, Nora shared that our movement of cattle, if you study the movement of dairy cattle through this country, it is impressive. They just move, and they move from state to state. We raise heifers in as young animals in one state. We move them as maturing heifers in another state, and we bring them to milk in a different state. And these are all economic measures that are important to us to be efficient, that we move our animals to where it's most beneficial from animal welfare and from the economics of raising those animals, and then bring them back to the dairy farm. So the biosecurity scenario is just going to be very different. For beef cattle, would be another story as well. So it brings me to my thought of we've heard, or I've heard a lot, and it's been mentioned a little bit here today, eradicate. And I've heard allow the disease to burn out. These are terms that, and I think that, I think it was Dr. Friedrichs that said at the beginning that we all use different terms, and I mean the same term, but with different meanings. To me, eradicate or let a disease burn out is something that would tell me that, we're going to get rid of that disease. And when I sit back in March and April and we're talking to people at the different federal agencies, my first question is, okay, we know this is transmitting between cows. We have no doubt about that. Is it transmitting back from cows to birds? I think we're very clear that that has happened. I think Michigan was one of the first states to see that, and we know that that's happening. So then the next question is, are the birds transmitting it back to cows? That was my first question to everyone back in March. Are the birds going to be able to transmit it? And I haven't heard the final answer on that. I don't know if we have done the definite research on that, but that's the first research I would have done, because then don't ever think that it's going to burn out or that we're going to eradicate, because we have migratory birds that are coming soon. Once again, they've been up somewhere enjoying themselves, and they're coming back through in the next month or two. And we don't know what they're going to bring back from this new virus and what's going to all happen with this disease. So the biosecurity issues are important. I think that, while herds are infected, movements of cows should, be restricted. We should do certain things that we've learned. But to me, back since March, I have been hollering vaccine, vaccine, vaccine. And I appreciate Secretary Vilsack's willingness that he has opened up to look into this vaccine. I continue to urge USDA to put this on the top priority, because when you ask about biosecurity, Governor, I share with you that we will not be able to have enough biosecurity to slow this down if this pattern of cow to bird and bird back to cow and migratory birds, this is going to be an endemic scenario. And our best bet is to do the best we can with biosecurity, especially during disease process, but it is a vaccine, and an efficient, efficacious vaccine, that is going to help us the most to be able to reduce the amount of disease, which reduces the exposure to humans, which reduces probabilities of what we pray that we never see.
Well, I appreciate that's a very direct answer. The best biosecurity would be an effective vaccine, right?
That is correct.
I appreciate the answer and identifying the complexity and the differences between dealing with dairy and birds, for sure. So thank you very much for your candor and your answer.
Thank you.
Senator Daschle.
Well, thank you all for your testimony and the extraordinary information sharing you're providing us today. Dr. Wineland, Dr. Parker talked about how critical it is for us to appreciate the importance of collaboration and cooperation. And I'd just be curious if you could drill down a little bit more on the degree to which you are satisfied with the cooperation and the collaboration with the federal government, and what, if any, improvements you'd like to see made as we look at that relationship.
So I think collaboration, cooperation can always be improved. I think we were dealing with extraordinary circumstances, and certainly there are things that could have been done better as we look back in terms of coordinating messaging, decisions, and really sharing information amongst the states. There were calls of affected states. Unaffected states were left out, and I heard a lot of complaints from my colleagues about that. I think the whole trust thing figures into that. I think as soon as you get on a conference call and you're talking to 50 states, the difficulty of keeping things sensitive, quiet, that need to be kept so become more difficult. So I think we can do better.
Thank you. Dr. McCluskey, we've talked a lot about trust, and you so eloquently described the circumstances that producers are currently facing. I don't think we've explored at all the challenge around misinformation. A producer has to rely on accurate information. And as we look at social media and technology today, it just seems almost in every context, misinformation has presented new challenges and real obstacles to acquiring the best and making the best judgment one can. How do your producers address that? And to what extent is it a problem?
You know, I believe that in this particular case, it has been a big problem. When I have talked to our dairy farmers, it is interesting to hear the different misinformations that are in their minds and what they're hearing. And it is a constant reassuring that the situation is such and not what they're hearing or being told. So again, I think that the way to solve that is through what we've been discussing here and establishing that relationship at the farmer level, at the state level, with everything we've mentioned before, where there is clear communication. Because if you ask 20 farmers today that have been exposed or around the disease, you would hear 20 different things or at least 10 different things. And it's because there has not been a real clear communication set between the real knowledge that we have to get in a trustworthy way to the farmer. So I think we solve that problem together with many others with the discussion we're having here, that a major focus to work with farmers and listen to their concerns and have them listen to the importance of them participating and reporting, and that we will have clarity in both ways and support each other and protect their information is a way to solve not only the communication issue, but the reporting issue.
That's very helpful. Thank you. Thank you all.
Jim Greenwood.
Thank you. Sorry to keep beating the trust issue to death, but I want to raise one more thing. It seems to me that if you're a poultry operation or your dairy farm, and you're considering whether you're going to voluntarily report or your veterinarian is going to report that there's the virus is on the operation, it seems the trust thing has to do with what's going to happen to me when I report. So if I have to depopulate my flock, am I whole? Am I made whole? If I have to quarantine my dairy farm, am I made whole financially? So could you just talk a little bit about the incentives or disincentives to reporting and the extent to which those producers can trust that they'll be okay financially and otherwise?
I can start on that. So I mentioned the Red Book. USDA has a lot of procedures for how we manage when there is a finding of HPAI in poultry. And that includes covering indemnity for the birds, covering the cost of disposal, covering all those things that they have to do to clean up and get back in business.
And that's all covered, it's reimbursed 100%?
It's reimbursed by USDA. They're not probably 100% whole. I mean, they have that downtime that can't be made up. So that is a challenge. I think for poultry, though, the birds are dying. So they really have no other option. Whereas for dairy, we didn't have until USDA stood up any kind of payment program. The ELAP program, I think, started July. Does that sound about right? So prior to July, our herds that had any issues were on their own to deal with those issues, unless states were able to do anything to help them. We did a little of that in Michigan. It was helpful, I think, but not enough. It didn't make them whole for the losses that they were experiencing and the challenges.
So just to be clear, so after USDA action, if your dairy farm is quarantined, are you liable to be at a significant financial loss today?
So we did not quarantine our dairy farms. We asked that they restrict their movement such that they would not be exposing other farms. So lactating cows needed to go direct to slaughter. I can't speak to whether they suffered financial impact of the prices they received, but it would be hard to imagine that there weren't some consequences there. And then other movements were allowed to continue. We asked that they keep track of where those animals were going in case we learned that other classes of cattle were also a risk of spreading the disease.
So I think you said earlier that the state has not decided to quarantine any dairy farms yet. That seems to beg the question as to at what threshold might that happen. And so if you reach that, I mean, the question is, are you clear on what that threshold would be? I mean, is there a document somewhere that says if this happens in a dairy farm, then we must quarantine? And is that all, is what would follow from that all clearly delineated?
I would say there is no document. I would say that it would be a judgment call of if we were needing to stop movements and felt like that was the only way to do it. I think I want to go back and explain a little bit why we did not quarantine, because within the producer community, a quarantine is viewed as you cannot move anything. And in reality, a quarantine can be very flexible and allow movement of different classes like we have done. But that would have created the misinformation that we've been talking about. And so in part, that's the reason we did not. If this disease were to become more, in earlier panels, there was, what's your worst nightmare? If this were to become a bigger issue for cattle are dying in great numbers, that would definitely change the picture, and there would be a quarantine and a hard stop of everything in order to address it.
Dr. McCloskey, you want to add anything to that?
Yes, just to add on to what Nora's saying is that it seems to be a disease that the transmission through milking cows is so much higher. Very, very little transmission in animals that aren't milking. So most of the quarantine is focused on a group of animals of not moving milk cows, and moving animals from your farm to the market to slaughterhouses it was an allowable movement during quarantine. And moving animals, young animals from where you may be raising them into your farm was also allowed. So the financial, damage of that was limited. It wasn't a huge amount. Some people sell animals, milking animals to other farmers for profit. So in those cases, they would be hurt. But in its majority, I think it was a very positive move to recommend to dairy farmers that had the disease not to move animals. If you trace the California, I think it's traced very clearly back to Idaho, of milking cows moving from Idaho back into California that had a history of had moved there and then moved back milking, and the disease then appeared in California. That's true of what happened in Michigan from some of the herds in the central West Texas got moved, not central, sorry, but West Texas got moved into Michigan, and one herd in Ohio. And that was a movement of milking cows. So at this stage, that type of quarantine seems appropriate and not financially ruining to the dairy farm. It's short; it's 3 to 4 weeks because of how quick the disease moves through the herd and out. So the measurement, I believe, I'm not sure how they did it in Michigan. I think it's how it's being done in California, is by bulk milk tank sample of the virus, and then it's released at that time. And it seems to be a relatively short period as compared to other diseases.
And my last question, we talked almost exclusively about chickens and dairy cows. Has this not been an issue with turkeys or beef or hogs?
Turkeys, yes. In turkeys, it's an issue. Absolutely. Yeah. So
not beef
poultry
cattle
in general, but no. Again, even in our young animals that are dairy cows, and I would say to a big extent, those cows that are milking cows that are in their stage that we call dry cows that are not milking, We're not seeing any tremendous issue there. We're not seeing any issue in the young animals. Those two animals, as bovine, are acting very similar to an animal in a feedlot that's just being fed, and so far we have not seen, you know, any serious problem. I don't know if we've done serology to demonstrate that we have it in some of our feedlots. I don't have that knowledge. I would think that we're working on that, but as far as knowing of a disease process where we're diagnosing animals that are sick, that's not the case.
Thank you.
Thank you. Thank you. This has been an extraordinary panel. We can't thank you enough for coming and sharing your insight. Thank you very much. Wendy, you have an announcement?
Hi, everybody. I hope you guys have enjoyed this great panel. Before I dismiss you all for lunch, I did want to announce our social media raffle winner. Thank you for following us on our platform and sharing our content from today. Today's winner is Christina Sanders. Is she here? Woo. If you won't mind coming up to receive your hardbound copy of the blueprint signed by our commissioners and a photograph with everyone up here.
All right. Welcome back, everyone. And thank you for our panelists for joining us. This panel includes Janet Hamilton, Executive Director of the Council of State and Territorial Epidemiologists. Yuri Fesco, Dr. Yuri Fesco is the Senior Vice President and Chief Medical Officer at Quest Diagnostics. And Christy Pablionia. Yep. There we go. As Executive Director of Veterinary Diagnostic Laboratories at Colorado State University. And we'll start with you, Dr. Hamilton.
Great. Thank you so much. I really want to start by thanking you for the opportunity for being here today. My name is Janet Hamilton. As the Executive Director of the Council of State and Territorial Epidemiologists, or CSTE, I am representing more than 6,000 applied epidemiologists working in U.S. health departments. I myself am a former epidemiologist working at both the state and local level, and I am bringing that on the ground perspective and experience to you today. Responding to introductions of diseases and conditions of unknown etiology is a critical public health function, with recent examples including Mpox, Zika, Ebola, 2009 H1N1, HIV/AIDS, and e-cigarette or vaping product use associated with lung injury or EVALE. In the fight against a pandemic influenza virus, timely information from epidemiologic tracking systems will play an integral, increased, and evolving role in supporting the massive public health response, and most importantly, directing public health action. While there are many things that I could talk to you about today, I want to focus in on two areas. And first, I want to acknowledge that our public health data infrastructure is in dire need of investment. In fact, in 2018, pre-pandemic, CSTE published a report called Driving Public Health in the Data Fast Lane. This report was instrumental in shaping the exciting work that is happening at CDC around data modernization today. We have made a lot of progress, and we have a lot of work remaining, and a lot of investments still need to be made for us to have true success where data moves as fast as the disease. As we think about goals and recommendations at the federal level regarding public health data systems, it is critical to first consider the role of the applied epidemiologist and the importance of data modernization at the state, tribal, local, and territorial level. With that in mind, there are three main points that I will be covering today. First, we need a strong and thriving applied epidemiologist public health workforce. It is the foundational component of a strong national public health system. Secondly, data modernization of our systems is needed now more than ever. Public health data are not only needed during an emergency response, it is necessary for people and communities to thrive by rapidly detecting, identifying, tracking, and responding to daily public health threats of all types. Simply put, it is how we make decisions and know if the decisions made are actually making a difference. Third, federal funding cannot come in boom and bust cycles. We need to be serious about our investments if we want to see serious results and not create a beleaguered and tortured public health workforce. First, I want to talk about the applied epidemiology workforce, the people on the front lines in our communities working to protect our health every day. The applied epidemiology workforce is at a critical moment post-pandemic. Just yesterday, CSTE released the 2024 Epidemiology Capacity Assessment, which is a comprehensive look at the applied epidemiology workforce across the entire United States. The findings are alarming. Applied epidemiology workforce and capacity needs in health departments remain unmet and are at risk of declining further. With the end of COVID-19 funding, states anticipate losing over 1,000 or 1/5 of the applied epidemiology workforce. And yet today, even before pandemic funding goes away, an estimated 2,500 additional epidemiologists are needed at just the state and territorial level. Let me be clear, without epidemiologists, there is no one to rapidly detect, control, and most importantly, respond to infectious disease outbreaks. Secondly, I want to talk about data modernization. Public health agencies at the federal, state, tribal, local, and territorial levels work together. Epidemiologists get public health data from multiple sources, hospitals, healthcare providers, labs, and vital records to make sense of it to inform public health action. State health departments then provide those data to the federal government to inform the federal government's public health response and help to prioritize resources at the national level. But first and foremost, we need a strong data infrastructure on the ground in public health jurisdictions, especially at the state, local, tribal, territorial levels, where the response happens, where public health actually intervenes. There are 5 core data sets that need investment now. These include electronic case reporting, syndromic surveillance, labs and electronic laboratory reporting, the vital records system, and NNDSS, or the National Notifiable Disease Surveillance System. While the use of modern and efficient electronic data exchange is moving forward, applied epidemiologists often must resort to using antiquated technology and manual data processes. Further, health departments also struggle to keep up with the pace of technology. Our public health data systems will continue to need updates and upgrades, and the staff supporting these critical systems will need ongoing training. This is why data modernization is so important. It is a long-term commitment to building and maintaining world-class public health data systems and a workforce that meets the nation's ongoing need to safeguard health. Thanks to federal investments, work has begun to build a standards-based interoperable public health information ecosystem ready to confront emerging threats. But we are at a critical moment. More work is needed here to ensure we do not eclipse and actually lose ground gained. Today, jurisdictions are making decisions about what systems to turn off or what may not be able to be backed up sufficiently in order to ensure it is available when disasters hit. Lastly, I want to talk about what we can do right now to support the applied epidemiology workforce and data modernization efforts. We need sustained and adaptive federal funding. Without federal funding, epidemiology work is simply not possible. More than 80% of epidemiology activities and personnel in states are federally funded. Epidemiology activities in territories are almost solely funded by federal dollars. Our specific ask for federal funding from this committee's recommendations is to first increase top-line funding for CDC, the most important source of funding to support public health systems and workforce across all states, territories, tribes, and communities. Second, to increase the federal-based funding for CDC's epidemiology and laboratory capacity, or ELC program, to at least $120 million annually to support nimble, response-ready epidemiologists able to handle any disease threat. And third, to increase annual funding for public health data modernization to at least $340 million to ensure jurisdictions have the ability to pursue data modernization efforts and hire full-time epidemiology staff to implement data modernization efforts. And with that, I thank you for your time and look forward to your questions.
Thank you very much. Dr. Pesco.
Okay, thank you guys for having me at the commission. So good afternoon, I'm Yuri Fesco. I'm the Senior Vice President and Chief Medical Officer here at Quest Diagnostics. As Chief Medical Officer, I am responsible for overseeing medical affairs, including clinical development, health plan policy support, and new services, as well as care delivery models. I lead a team of scientific communications for the company and represent our medical team of approximately 700 MDs and PhDs. Thank you for the invitation for me to tell you more about Quest Diagnostics and specifically to our work to develop and rapidly scale diagnostic testing for outbreaks of avian flu such as H5N1 and other emerging infections. Our company's purpose is creating a healthy world, one life at a time. We emphasize the idea of working together because healthcare, as you know, is complex. We know from COVID that it involves collaboration between private and public entities. Quest is one of the largest clinical reference laboratories in the country and plays a critical role in the healthcare ecosystem. A few facts. Quest serves about 1/3 of the US adult population every year and half of the physician and hospitals in the United States. We have 7,400 patient access points across the US and perform approximately 550,000 tests a day. This is done through 26 regional laboratories that run 24/7. We have a nationwide infrastructure of clinical laboratory services and a global processing of specimens for multiple countries. The reach and infrastructure is important for the readiness and response and serves as an extension to some extent of public health laboratories for testing. As the pandemic demonstrated, a laboratory infrastructure is critical and plays a critical role in the healthcare ecosystem. Regarding avian flu, with COVID, our country didn't have laboratory capacity until after the pandemic was declared. Avian flu is different because it's a form of influenza, and the US has an existing infrastructure for influenza testing. Quest Diagnostic provides several testing options for influenza A and other respiratory viruses through its extensive networks of laboratories across the US. In addition, Quest offers assays that will also type the seasonal human influenza strains, i.e. H1 and H3. The current influenza subtyping tests through Quest Diagnostics and other laboratories will not specifically identify influenza A as strain H5, however, would identify it as a non-typable strain. However, we were to determine if a patient with influenza A sample were to detect an H5N1 virus, that would be through additional subtyping that would be needed to identify that substrain. At the present time, CDC and other public health labs provide H5N1 testing, but we're one of 3 commercial laboratories that was recently granted an award from the CDC to specifically develop an H5N1 test. We were also recently received CDC funding contracting for the establishment of warm-based testing capacity, as well as data sharing with the CDC to hasten the public monitoring. Coordination between commercial laboratories and industry as well as the CDC and federal agencies, including the White House, is critical to the nation's ability to rapidly respond to emerging and future infectious disease events. These recently awarded CDC contracts are a positive step forward and demonstrate the progress that the federal government has made to improve the nation's ability through commercial laboratories to urgently respond to an emerging infection. So, lessons learned from COVID. I'd like to take a couple minutes just to speak about a few lessons that we learned from the COVID pandemic. Looking broadly at pandemic response, there are really 4 phases that we see at Quest Diagnostics. One was the discovery phase, which includes surveillance activities to identify potential emerging infections. And this is done predominantly through the public health sector. Number 2 is what we call the chaotic phase, where public health and commercial laboratories scramble to develop and distribute new tests in this emerging infectious agent. Number 3 is the increasing capacity phase, when laboratory systems, primary, national, commercial laboratories, react quickly to expand testing to meet commercial demand. And 4 is the stable phase, which occurs when there's a balance of capacity and demand and is reached. This would represent where we are now with SARS-CoV-2, Mpox, Zika, West Nile, et cetera. Our emergency response preparedness efforts should focus on implementing changes to shorten the time between these phases. Cadence regular communication between the involved processes to identify potential emerging infections, i.e. the CDC and national reference laboratories, to know what areas to focus on and what threats exist around the globe. Susan Van Meter, who served as the president of the American Clinical Laboratory Association, co-authored a paper, a proposal for a national diagnostics action plan for the United States, along with Tom Ingsley, the director at the Center for Health Security at Johns Hopkins, who also served as a testing coordinator for the White House COVID-19 response. The paper included a recommendation to establish a permanent public-private national testing forum and focused on preparedness and response to disease. This forum would ensure continuing conversation and alignment. One other necessary change would be closer coordination between public health and commercial test developers to ensure that tests can quickly be developed and be performed on large-scale instrumentation in high-throughput commercial laboratories. This would also include access to sample and controls, which are critically important for validation purposes. Finally, stockpiling of supplies is critical to ensure safe collection and transport of specimens for testing, and regular funding for warm-based testing, meaning having the ability to increase capacity before commercial need is ready, is critically important. With that, I will turn it back. Thank you for having me.
Thank you. Dr. Pabelonia.
Good afternoon. My name is Christy Pabelonia, and I'm the Executive Director of the Veterinary Diagnostic Laboratories in the Veterinary Health System at Colorado State University. Our laboratories provide a wide array of diagnostic testing for all animal species, and we receive samples from across the United States and internationally. Our laboratories belong to several national laboratory networks, including the CDC's Laboratory Response Network, where we test for potential bioterrorism agents such as plague, tularemia, and anthrax, and the USDA's National Animal Health Laboratory Network, also known as the NALN. The NALN is a robust network of 60 university and state and federal veterinary diagnostic laboratories across the United States, focused on foreign and emerging disease detection and response in animal populations. Activities of the NALN are harmonized across all network laboratories, including testing assays and assay development, equipment, standard operating procedures, training and proficiency testing for laboratory personnel, reporting of results to state and federal agencies, and overall management of surveillance for and response to foreign and emerging pathogens. Our network provides large-scale capacity and high-quality testing. As part of the NALN, our laboratories at CSU provide ongoing surveillance for pathogens such as bovine spongiform encephalopathy in cattle, chronic wasting disease in cervids, and classical swine fever virus in domestic swine. We've responded to a number of emerging pathogen outbreaks as part of the NALM, including Newcastle disease virus in domestic poultry, vesicular stomatitis in horses, and national outbreaks of highly pathogenic avian influenza virus in wild birds and domestic poultry, and now transmission of H5 influenza A virus within cattle populations and spillover to domestic cats. Colorado has responded to the recent H5 influenza A virus outbreak since the virus was first detected in wild birds in the US in late 2021. Our response is led by the Colorado Department of Agriculture with really strong collaboration between the Colorado Department of Public Health and Environment, the USDA, and our laboratories. The virus has affected more than 8 million commercial poultry and more than 17,000 backyard domestic poultry in our state. And until a couple of days ago, Colorado had the highest number of influenza positive dairy premises in the United States, with the detection of the virus on 64 different dairy premises, which is 74% of total licensed dairy herds in Colorado. And then recently, California now has more positive influenza A virus positive premises than Colorado. We've also detected the virus in 6 cats in our state who all died from the infection. These detections have had significant financial implications to Colorado producers and significant impacts to animal health and our food supply, plus ongoing concerns from a public health standpoint regarding further spread of influenza A viruses in animal populations and the potential for zoonotic transmission to humans. The Colorado Department of Agriculture implemented mandatory bulk tank milk testing for Colorado dairies in July of 2024, a commendable action to prevent further spread of the virus in our state. Since late 2021, our laboratory has performed more than 32,000 influenza tests on samples from wild birds, domestic poultry, cattle, pets, and other wildlife. This is not our first time responding to a large-scale outbreak. Starting in June 2020, our laboratory assisted local and state public health agencies with human SARS-CoV-2 testing more than 280,000 human samples over a 2-year time span. We were able to respond due to significant one-time financial support for equipment and infrastructure from COVID-19 related federal funding, and because of the capacity we had built in responding to animal disease outbreaks as part of the NALM. However, there were challenges in our response as it took months to hire enough staff, train those staff appropriately, expand infrastructure, such as equipment and laboratory biocontainment and functionality. As we all experienced early in the SARS-CoV-2 outbreak, laboratory expansion was essential to response to the outbreak. We want to ensure a fast response to an outbreak of an animal pathogen, and the NALM is seeking financial support to be able to do so. The NALM is essential to the health of food animal agriculture, food security, and bioterrorism surveillance, and has a direct impact on the US economy. The NALM has been authorized for funding at $30 million since 2012. However, the network has never been fully funded to this level and is currently standing at a bit under $22 million. We are requesting an increased authorization for the NALM in the Farm Bill to $45 million due to rising costs of laboratory operations and infrastructure. And while the non-laboratories have been able to respond to current outbreaks, the outbreaks have been limited in scope. A large-scale outbreak, such as an outbreak of foot and mouth disease in the United States, would require significant veterinary laboratory capacity and equipment, facilities, information technology, staffing, and training, so that we can respond quickly with high-quality testing and real-time reporting of results to state and federal animal health officials. For the NALM laboratories to be successful in responding to a large-scale outbreak, we need to fully fund the network so that laboratories are fully prepared to respond quickly to protect US agriculture and the US economy. Thanks for the opportunity to speak to you today.
Thank you very much. Okay, Dr. Hamilton, you talked about the insufficiency of epidemiologists, and I think you also said epidemiology workers besides epidemiologists. Is that correct? It's both the epidemiologists themselves and support staff?
My data that I presented was specific to the applied epidemiology workforce. That's what CSTE did its assessment on. However, I would say that the entire public health workforce is in dire need of support.
Mm-hmm. And so do people, is there a problem with there being an insufficiency of epidemiologists and the epidemiology workforce coming out of the educational system? And if so, is that because of economic reasons? They're not without, I assume that most of them are paid for by public entities as opposed to private entities. I'm sure the private entities hire some, but can you talk to the sort of what's at the bottom of this?
Yeah, absolutely. So I think maybe I'll look at your question in two parts. So one, how are people being trained out of schools of public health? And then what does the workforce look like? So when we look at the shortage and the way that the epidemiology capacity assessment is conducted, and it's been conducted since 2001, so we have a lot of longitudinal data. It is, here's the resources and the staff that I have, and every state quantifies those. And we have had 100% response rate from all states. And this year we also had 100% response rate from all territories. And then what do you estimate is needed? And then those numbers are gathered. So unfortunately, regardless of the state or territory, most states are funded solely by CDC when it comes to the epidemiology workforce. And therein lies the crux of the budget issues. So when CDC isn't funded, then the jurisdictions are not able to support, fund, and create positions. So that's why when you look at the epidemiology workforce, and as I mentioned, 80% of the epidemiologists in state, local, tribal, territorial health departments are funded through the CDC's budget. So then I will also say there are some specific areas. So the epidemiology and laboratory capacity grant has a specific line that hasn't been increased for almost 10 years. So actually there's less money that's available there to support nimble, response ready epidemiologists. And I think we can all appreciate at the beginning of any response, you don't necessarily have an epidemiologist that's solely dedicated to Mpox or COVID or whatever the threat may be. So that puts a lot of strain within the workforce itself. And then in terms of training, I do think there's an opportunity for schools of public health to improve the training for the workforce that's actually coming into applied epidemiology. And CSTE actually released the applied epidemiology competencies, which can be utilized now by schools of public health to actually improve the training so that when graduates leave schools of public health, they actually meet certain types of competencies. And I think we definitely see that there are graduates that are not well prepared to enter the applied epidemiology workforce. Another really critical component where we don't see support and is one of the most crucial places to growing the public health workforce is through fellowship programs. So if you look at the applied epidemiology workforce, a large proportion of them enter actually through fellowship programs. And we're actually seeing declining resources for those fellowship programs. So CSTE, for example, is funded through CDC for the applied epidemiology fellowship program, and about half of that funding has been cut. Again, that's federal resources and dollars. So I think that's another opportunity to really improve people entering into the field. And there are many challenges that health departments face in terms of staffing and other abilities to hire, et cetera. And that's why fellowship programs are so important to actually bolstering the workforse.
So if there was enough federal money, if you could just say what the numbers should be and Congress gave you that amount of money for that line, would there be enough epidemiologists to fill those positions if they were fully funded? Or are there insufficient people going into this field because they don't see a sufficiency of funding in public health departments to give them a career path?
Sure, I see your question. So promoting public health as a field and epidemiology as a field is absolutely needed. And we need more promotion into high schools and middle schools about what it's like to become a disease detective and what you can do in the public health field. Absolutely.
I would think in the wake of COVID, it would be an interesting field to go into for people of that age. Thank you very much. Dr. Fesco, I want to understand something. So you do, with all of your labs, you do, I think you said 550,000 tests a day, something like that. So when you have a surge, as you did in COVID, and you could have in another pandemic, do you have the surge capacity to meet that? Is there a sufficiency of people and labs to do that, or does that need to be enhanced?
So there's two parts to it. We talked about warm-based testing, where something that is not, hopefully we don't have an epidemic of avian flu, but if we did, you've got the capacity ready to go when it hits. The issue for most commercial laboratories and most hospital laboratories is that until you are that starts to happen, you've got a very small capacity that we've sort of built that is part of this warm-based testing that the CDC gave us a grant, which is great, to basically establish it. But it is really for 2 laboratories right now to basically make sure that you have an assay, it's ready to go, the instrumentation, you have a standard operating procedure of how you're going to expand that testing. But the expansion does not happen under the warm-based testing because there's no demand at this point in time. That is one of the recommendations that was made by the Susan Van Meter paper, was basically getting ready for that, saying, listen, instead of waiting for a pandemic to happen, when we know about these threats, sort of saying, listen, yes, we want you to have a warm-based testing program, but we also want you to invest in the staff that's ready to go should we need this. And that may be in excess of capacity. The issue is in any healthcare system, any commercial laboratory, it's prioritization of those resources. If there is a funding that sort of says, yes, this is the emergency preparedness, yeah, absolutely, it's ready to go. Right now, we've taken the first steps to doing that, through this partnership, but it isn't a regular occurrence that's been happening up until this point. So yes, we have the beginnings of it. I think it needs more investment to get to the state that I'd love to see it in, which is, yes, we have it ready to go in 6 laboratories. It's a very small component right now, but we could expand it tremendously overnight.
And in COVID, was there sort of a bell curve? First, we had no diagnostics, then we developed them, and then labs like yours were doing, and then the at-home tests become prominent, and that
every single one is different. So, Quest performs in lots of different locations. It can be a hospital setting, it can be a physician clinic setting. Sometimes we do outreach for hospitals, and those are really either point of care or very close to the patient testing. When you go to a larger reference laboratory where you're doing subtyping, that's going off and it'll take 24 hours to get that back. Some infectious agents you need to know immediately. And some of them, have certain containment things where it really even can't even be done through Quest. It has to be done through a public health laboratory because there's containment issues, et cetera. But we sort of service all of those different markets. Right now with avian flu, H5, it's the subtyping that's taking place. So you have an idea that the patient has something, and that's being done very close to the patient through some sort of a rapid care, but it's not giving you the subtype that it is the H5 variant. Initially that would probably go off to a large centralized laboratory. Over time, as that diagnostic expands out into the market, it'll end up being in every hospital, but that will take time, and that's sort of what we're hoping to prepare for.
Thank you. And Dr. Papalonia, could you explain what specimens come to the university labs? How does that work? So that do you receive specimens outside of Colorado, and so which specimens go to you as opposed to other laboratories?
So in Colorado, we receive specimens from all across the US. We also receive them from international countries. And that'd be similar to other labs across the null network, mostly, again, university or state federal labs. Typically, we're doing higher level testing than would go to the commercial veterinary laboratories. So we're doing the kind of higher level PCR testing, next generation sequencing, that sort of work. Right now for cattle influenza testing, mostly what we're receiving are milk samples, but we also receive carcasses for necropsy investigation. We receive nasal swabs. We're receiving cat samples from neurologic cats. So we see a wide variety of sample types and species at our university laboratories.
Thank you very much, Secretary Shalila.
Cat samples. Make a remark about that. Let me follow up on the laboratory question, because one of the things that we learned during COVID is that while we had all these research universities across the country, they weren't certified, or the capacity wasn't built to use them along with the state labs for diagnosis or for other kinds of things that we needed during COVID. Ms. Hamilton, what role have the state epidemiologists played in terms of policy related to those kinds of laboratories and expanding the role of those laboratories? I understand the need for more money for epidemiologists at the state level, but what about the capacity within the state?
So that's a really great question. And I think when you look at the capacity within the state, so I'm just going to quickly say within the state is federally funded. And even, as you heard our great colleague from Quest talking about their new contract, that's a CDC federally funded contract. So the work that happens at the states, it is the federal dollars that supports them.
Well, and much of it is NIH dollars for those laboratories.
Within the public health system, it is not NIH dollars, it is CDC dollars. But if you look at a state,
within the university laboratory facilities, it's often NIH funding.
So I would maybe let a university lab comment specifically on that. I think one of the challenges with university labs is they are not connected into the public health system. So even if there is research testing that happens in a university setting, there's no way for that data to begin to flow into the health department. Now, I'm talking about the human health side. I think, my colleagues can talk more about the animal health side, but that sort of set of processes, how do specimens arrive? What does the testing look like? How would the data then be shared? That's not part of the integrated current public health system and sets of responses. Now, what I would say, your question also was, what does state epidemiologists do? So I think there are a number of jurisdictions that are looking at different types of university partnerships to help support them, but that's not really a high throughput kind of process. And so again, it's really the bedrock is the state public health lab system. And certainly I would encourage you all to reach to some of our colleagues at APHL for that. And then the commercial laboratory sector that supports the human health side.
What kind of questions are you getting from epidemiologists about the current HPAI outbreaks?
So I think a lot of the questions that are circulating among the epidemiologists right now, there are not a lot of human infections in today's world, which is a good thing. In the instances where we have identified human infections, again, they have been mild infections. So the question is, what is going to be the best source to detect the infection? People actually have to get sick to seek healthcare. And then we traditionally find out about those individuals. So I think that's one component. And I think in particular, when we look at the, again, the focus of where are the people who may be exposed, as we've already talked about today, many of those are workers on farms, and we don't necessarily have the support and resources for diagnostic programs amongst those workers. I would also caution, as we think about this set of work and activities, there are many health needs for those individual farm workers, and a mild case of conjunctivitis probably is not at the top of their list. So what other types of mobile services would we be smart to be providing these individuals as a means for building trust and then helping them accept some of the things that we may be asking them to do from a public health perspective?
One final question for Dr. Fesko. Has the federal government engaged you in how you would scale up if there was another pandemic?
To a limited extent, the CDC warm-based testing would be probably the biggest extent at this point in time. But to your previous question, that's part of the reason they did this warm-based testing is they wanted us to basically bring up an H5 assay so that non-typable influenza specimens, you had an idea that, listen, you've got something going on in this particular population, and it's going to be very important for, a laboratory like Quest to be in contact with Janet's organization to basically say, yeah, we have something here. And, if we subtype it that it is the H5 variant, you get a head start on quickly identifying where that population is. And, then it goes into the public health arena to help to determine what are the containment measures, what are the measures you're going to do, how severe is this outbreak, what needs to be done. But this is the first one, that warm-based testing, that's the first sort of expansion. It is also, this is sort of the first entity that we've seen that we're doing warm-based testing expansion before anything has ever happened, which is great to see that.
Senator Daschle.
Well, Ms. Hamilton, let me just compliment you, especially with your strong advocacy of the public health investment necessary to meet the challenges as we go forward. I couldn't be more in agreement with that. I'm not sure who this question might be directed to. I'll start with you, but certainly invite anybody else on the panel. I'm just curious how we make the decision, how the federal government makes decisions on vaccinations. That we just started vaccinating wild condors recently because of the increased lethality of the current strain of H5 to wild birds. But I'm not sure I know on how the decision-making process on something like that unfolds and how the program is executed and really what vaccine is being used. Can you or somebody on the panel talk a little bit about that?
I can make a few comments. And I think, again, this is where our colleagues at CDC are so helpful in terms of really being able to help organize some of the discussions and conversations. And there's also ACIP, which makes recommendations once a vaccine is available. In particular, first you need a vaccine. That's the first thing. I think in this situation, we do have a seasonal influenza vaccine. And I think we all recognize that even though maybe a seasonal vaccine is not perfect, keeping people out of hospitals makes a difference. And it helps the healthcare infrastructure be able to respond more effectively. So in today's world, it's really how do we identify critical populations that may be at highest risk for infection? So in this situation, those workers on farms, et cetera, what would be good strategies for being able to actually offer vaccines? I think earlier in the discussion, it already came up that we actually don't have a federally funded program for vaccination for adults. And when you look at access, especially among lower resourced individuals or communities, not having a federally funded vaccine program for adults is clearly a limitation in this country. And I think then just going a little further towards prioritization, it's hard at this moment in public health where we have seen people turning against vaccines as a public health control measure. And I think we all heard Dr. Friedrichs this morning talk about what it meant when polio was widely circulating. And we can all appreciate as people in the world today that it is due to the polio vaccine that that's not something that our children are facing. So I think this is an opportunity also for the committee to think about what other real communication tools do we need to provide to really educate people on the life-saving qualities of vaccines and ensure that we have opportunities to actually combat some of the misinformation and disinformation that sadly is now very pervasive within our society.
Well, that's very helpful. Thank you. Dr. Pavlonia, you've talked some about this already, but I'd love to have you just drill down when we talk about your participation in the National Animal Health Laboratory Network. You talked about the role that USDA plays in providing assistance in diagnostic testing. If there are 2 or 3 things that you thought would be the most helpful in that partnership, what would they be?
So I definitely think the existing harmonization that we have across the National Animal Health Laboratory Network is of the utmost importance. It's harmonization not only in our testing modalities and the assays that we're using, but all the way from the point of acceptance of the sample to the point of reporting results. To kind of tap into one of the questions that was answered or asked earlier, it's not really the testing per se that's so hard. It's all of the other pieces. It's the data entry, the correct reporting of results. We HL7 message our results in real time to the USDA. Those pieces can be complex and are places where we want to continue to build our capacity on. So I think the harmonization is really important. I think that the work that the USDA national labs do to confirm results, report results, and then provide sequences out to the greater general public is also very, very important. And then I think really the most important piece that's happening right now with cattle flu testing is that USDA is covering the cost of testing for producers, which encourages producers to submit samples to our laboratories.
Thank you. Thank you all.
Okay, Dr. Troy?
You, Jim, go ahead.
Thank you all for your testimony. I was particularly taken by Ms. Hamilton's comments about epidemiologists. My wife is an MPH in epidemiology, and she's practicing, so she works with the FDA. So thank you for that. I just want to talk a little bit about federal integration with both the private sector and the states. I mean, all the people here have experience on the federal level, and most of our policy decisions are about federal. Can you talk a little bit, all 3 of you, about how you can see better integration with the federal government so that in the future, what Dr. Parker talked about with his One Health initiative, that it would be an actual integration rather than just a talking point?
Sure. Well, I can make a couple of comments. And I think, we work, live, and breathe in a federated country and a federated public health system. And so that collaboration and coordination between states and the federal government is critical to everything that we do within the public health system. I do think opportunities for improved collaboration, specifically when we think about the response associated with influenza. I've mentioned data. I am an epidemiologist, so I won't just have to say it again, but real support for the data to move from the healthcare system into the public health system. And I think ongoing opportunities for the federal government to convene those bodies or use other organizations to help convene the bodies to really work on development of consensus-based processes so that we can truly implement some of these data sharing activities. I think another opportunity that I would just highlight is, influenza doesn't always look like influenza. It looks like a respiratory disease. And so when someone is seeking care, they don't necessarily know that they have influenza. And the hardest disease to control is one that has mild symptoms where care seeking is not necessarily front and center, and severe outcomes. So, right, that's the worst scenario situation that we could present. And so I think the opportunities then to develop a vision and a coordination around an integrated respiratory disease surveillance plan that isn't just about influenza, but it's about influenza, COVID-19, RSV, as well as the animal-human interface. That's ultimately what we really need to be working on.
I would add a couple of the things that have sort of already been said, but on the reporting side, one of the big pain points that we've had is sometimes state and local regulations don't match the federal regulations, and it is very difficult to harmonize what we're reporting. Quest Diagnostics will touch all 50 states. If all of them are different, it's very difficult for us to meet the reporting metrics. The other issue is, we don't always have access to some of the questions that are being answered. A lot of the health systems are on electronic medical records, and we will get ICD-10 codes, we will get some information about the patient, but it isn't pervasive into the outpatient clinics sometimes, and we'll be on paper requisition. We will not get a lot of information about the patient. And so that's data that is necessary for public health reporting, and we just don't get it. At this point in time, we're not solely on an electronic medical record in this country, and it poses problems. The final thing that I would say is in preparedness, acquisition to samples to be able to validate these tests is incredibly important. So, we've talked about some of we talked a little bit about academic facilities potentially bringing up a test. The issue sometimes we run into is they'll bring up a test, but it can process 10 samples. And, for a large commercial laboratory, it's got to be able to process, a couple thousand a day. We have to know what the threats are that are coming. We have to have access to the samples to basically validate what we're doing so that we're ready for that day one and we can expand that capacity. Without that, we sometimes are hamstrung.
Yeah, I mean, I think in any response, you want everybody to be in lockstep with each other. So you want a lab like ours to be in lockstep with your state animal health officials, to be in lockstep with the USDA and the national laboratories. I think in our response to cattle flu, we're doing that very well. We're talking, daily, sometimes hourly, sometimes minute by minute we're talking, and that's very, very important that we maintain those communication chains. And that's why I think that having these networks, having these agencies where we all know each other and work together and work well together, that's of the utmost importance to the response.
Thank you.
Okay, thank you. I think I'm going to turn to Dr. George, our executive director, for some comments.
Thank you. I just wanted to point out to our audience that, or remind the audience that this was a topic that was very important to Senator Lieberman. His grandmother died during the 1918 pandemic, and he just continuously brought that up and talked about it. And he made it a priority for the commission, and we've hung in there and continued to talk about it for the last 10 years. I also wanted to say that while the commissioners didn't make it very obvious today, each one of the commissioners and all of our ex officios have a specific interest in dealing with influenza. All of them do. Senator Lieberman did. Governor Ridge was Secretary of Homeland Security when the National Strategy for Pandemic Influenza came out. Senator Daschle was chair of the Senate Agriculture Committee and is very interested in animal influenza, et cetera. Secretary Shalala has been talking about this for a while, and the need for localities to be utilized more than they are. The Strategic National Stockpile is not sufficient, for example, by itself. We have pharmacies on every corner where everybody's going to. They're not going to the Strategic National Stockpile to get anything. Jim has talked about it. Everybody has talked about it. So just to assure everybody that this won't be the last meeting we have about influenza, but it's really important to us. I also wanted to thank the commissioners and the ex officios and our staff, of course, for continuing to support the commission and be part of the commission. It's been 10 years for a number of us, and we're continuing. Topics like this are important and continue to be important, as does the rest of the work of the commission. I also wanted to thank our current fiscal sponsor, Hudson Institute, for serving in that capacity. And our major funder, Open Philanthropy, for their support and enabling us to continue. Lastly, I want to thank again the audience. A lot of you have been showing up to meetings like this for too many years to count now. It would be nice if we could do something about influenza and not have it be this perpetual seasonal and otherwise thing that keeps coming back over and over again. But until that happens, I think it's important that we maintain this commitment. People are dying. The number of animals that are now dying from influenza, it's just unacceptable. And as Paul Friedrichs said earlier today, it is of concern, no matter what the numbers are, that this particular virus is spreading to so many different animals is just something we have to keep track of and understand better. The commission wants to continue to help do that, and certainly we thank everybody for participating, not just as our speakers, although that's incredibly important, but also in the audience. Thank you.
All right, thank you, and thank the panelists again, and thank you all for coming, and we'll apparently see you soon.